All right, so what's the plan? Okay, one thing, what happened last term is the same thing that happened to you guys, whereas they had the exam on Friday. So like there was a week of material we weren't able to cover, and like in a review. So what I did for them is I made slides for the last week. So even though we won't be able to have a physical review, there are slides available for you guys. So since Kishore did an endocrine review for y'all yesterday and it's recorded, we're going to go quickly through that. I want to focus mostly on the high yield concepts, the clinical concepts. So we'll do that quickly. We'll take a break. We'll go through the week 2 stuff, which is reproduction. And like I said, the week 3 stuff, which I haven't covered yet, the review slides are posted for y'all to look at whenever. Okay, let's see. Share screen. All right. So as you know, here's the stuff, right? So we'll do endocrine first week of reproduction, and these slides are just for y'all to review, maybe after y'all see the material or closer to the exam. Your link to the YouTube channel is here in the About section. It'll bring you here. All of the reviews are here. They're private. So make sure you use the link. You can bookmark it and you're good. As always, this is not affiliated with school or IEA or anything like that. But you should join IEA. For you guys who did make honors last term, the deadline is September 1st. So make sure you get your applications in. Here's the link. The link's also in Scrubs. It's on your class page and stuff. All you have to do is submit your dean's letter. Make sure you get that in before the 1st. But for everybody, follow IEA on Instagram. We're going to start doing the facts of the day for each term, questions of the day, facts of the day type stuff. So that's good. And you could, we'll keep everything updated through there. Okay. I think that's all I had. So
before we begin, we're going to give a shout out to Zoom Med and Zoom MDDES. Yeah, we're using his link today. So check Will out. He's also an Anki Pro, like our friend Kishore. So Zoom MDDES, that's what it's called. So shout out to him for letting us use his link.
He also went to LSU, which makes him cool. So there's that.
Which makes him cool.
All right, so these are broken up. So the reproductive, and then like I said, this was for week 3. Again, y'all haven't done this yet, but these were just slides I wanted to put together. I kind of made it easy to see what I felt was important, right? So yeah, you can go through that when you have time. All right, so let's start with endocrine. I think in general, most people find endocrine a little bit more straightforward than reproduction. You know, for the most part, we do this feedback system, right? So whatever released in the brain or the pituitary, the downstream hormones that are made kind of feedback and turn everything off. So that's kind of the general idea. As always, I'm on Scrubs, Lindsey's dog mom. We have our stuff posted for you guys. I updated everything on here with all the extra questions and stuff, so you can see that. Now, let's go. All right, so when we look at the pituitary here, remember that anterior pituitary is going to be vascular structure, right? And you can see this lighter structure. That's because the posterior pituitary is the neurohypophysis, right? So those hormones in the posterior pituitary, those are going to come straight from the brain, and they're going to be stored there. And so this is a neurovascular structure, whereas this is more of just a vascular formation in the anterior side. Let's see. Yeah, and it's good to know like how what they formed, right? So with this neuroectoderm, with the posterior lobe, it comes through Ranke's pouch and it kind of forms through the brain. So you can see that there. Again, if you're confused, just remember nervous structures tend to stain lighter because the nerves, the myelin on the nerve, it's lipid, so it won't stain with H&E. So that's always the trick I use. You can even see it here. This is nervous structure here because it stains lighter. And yeah, and then of course, adenohypophysis refers to the anterior pituitary. Neuro is the posterior. They always like to ask, where are the hormones in the posterior pituitary made? They're made in the brain. They're stored in the pituitary, okay? Whereas the anterior ones are actually made in the pituitary. You can see these here, straightforward, just kind of definitions, the acidophiles versus the acidophils versus the basophils. They don't really ask about the chromophobes. Those are just, you know, they hate color, right? Chromophobes, so they don't really stain. But if you're looking for the acidophils, they'll be eosinophilic. Those basophils will be darker staining. And the mnemonic everybody uses is flat pig, right? So FSH, LH, ACTH, TSH, where, and those will be basophils, B flat, right? And then the acidophils, prolactin, and GH, acid pig, right? So that's what is in first aid. And then you could break them down even further. Somatotropes refer to growth hormone. You can see that here. Somatostatin is the big inhibitor of those. We'll get into that in a little bit. Prolactin is a mammotrope or lactotrope, right? So it helps with lactation. And it's stimulated. Now, they use these interchangeably, prolactin releasing hormone, but also thyroid releasing hormone. That's probably what they would ask in the test. Not super intuitive to think that thyroid releasing hormone would go with this, but it does. And another big point, I did the acid pig thing, be flat up here. Another good point to be made is down here, actually. Dopamine is the big inhibitor of the prolactin, right? So y'all haven't really come across this yet, but some people with schizophrenia, they take dopamine antagonists, right, to slow down those symptoms of hearing voices and stuff. Those dopamine antagonists are a good example. If you don't have dopamine, as one of the side effects of these drugs is lactation, right? So you don't have that inhibition. Yeah, good thing to know that right there is dopamine. Again, you can see here, anterior versus posterior. You can see this neurovascular structure coming through here straight to the posterior aspect. What is this one? SADPOX, right? There it is. SADPOX, that's how you remember. The supraoptic nuclei makes ADH, antidiuretic hormone, and then the paraventricular nuclei makes oxytocin. So this is a good way to remember that. Of course, these are both part of the posterior pituitary. Again, they are made up in the brain and stored in the pituitary. Yep. Okay. This is just from first aid. That's where I got these mnemonics from. And just some of the vasculature here, you can kind of see this. I think maybe Grace may have had a question about this, but you can see this secondary capillary network kind of forms in the anterior pituitary. And most of the blood to the anterior pituitary comes from the superior hypophyseal artery, whereas you could see this dual blood supply to the backside with the inferior hypophyseal. Now, when we talk about some of the clinical aspects of it, you can see this guy, growth hormone, right? So that would be a problem there. And then this kind of, yeah, I put a star here. You could see prolactinomas, it's cancer that would cause increased prolactin. So how could you treat that? Maybe give a dopamine agonist, right? Help to decrease the prolactin secretion. And then of course, growth hormone, acromegaly is referred to when adults get it. Gigantism is in kids. Somebody said acromegaly starts with A for adults. So that's a good way of remembering it. And then of course, we'll get to Cushing's disease and hypothyroidism in a little bit. All right, so we get to the adrenal gland. This is more, oh yeah. So, right, so good to know the cortex comes from mesoderm. And the medulla, as always, they love to ask questions about neurocrest cells. Why did the neurocrest cells provide precursors to the medulla? Well, because remember those, what are they called? Chromaffin cells are there, right? And those secrete catecholamines, right? So they come from neurocrest cells. All right, and then did I put the mnemonic here? Yeah, there it is, right? So as you go deeper you go, the better it gets. So salt, sugar, sex. GFR, it's not related to glomerular filtration rate, but it's easy to remember that GFR is the glomerulosis, the fasciculata, and the reticularis there. If you're looking, I think I have a better picture of it, yeah. You can see here, if they do give you a histology of this, the fasciculata tends to be a lot bigger. Like, it's hard to really tell here. It's not as prominent, but just remember the glomerulosa is kind of just this shorter layer here, and then this paler layer is usually larger, and that has to do with the fasciculata. You can see this here. Now for the glomerulosa, we're talking salt, right? So we're talking aldosterone. That's a primary precursor there. Angiotensin, remember the RAS system we talked about in renal, renin, angiotensin 2 or angiotensin. and aldosterone all work together to bring the blood pressure up. These will be your mineralocorticoids. And then once you go a little bit deeper, the ACTH is going to take over and control your cortisol, glucocorticoids, and then even deeper, the androgens are going to be made, your sex hormones, DHEA, which helps to make testosterone and stuff like that. All right, and you could really appreciate it here. You can see how much larger the vesiculata is there, the reticularis down here. Okay, so pheochromocytoma, they love to talk about this. Patient comes in with these episodic bursts of just hypertension, they're sweating, they're anxious, stuff like that. So, but remember they're episodic bursts, right? So the pheochromocytoma is a tumor of those chromatin cells. So they're in these little bursts, they're sending out catecholamines throughout the body. The thing they love to ask in the diagnostic criteria here is VMA. That is the breakdown product of those catecholamines. So whenever you see elevated VMA in the urine, you need to be thinking of pheochromocytoma. And just remember, it is a tumor of the chromatin cells. Okay. Yeah, I don't know that this is super important. I don't even know if they know. I think they said they don't exactly know. These just happen over time. These corpora Horacian, or I'm not even gonna try to say that. But you can see these little brain sand formations. I don't think they're pathologic. They just are something that happens over time. Now you can see the thyroid gland. When you see this image, you should immediately think the thyroid gland, right? These huge follicles here where thyroid hormone is going to be produced. And then you have these cells lining it as well. So this is going to help to regulate all of your thyroid hormones. Remember, you need iodine to work with that. Remember, when you think of the thyroid gland and you think of hyper versus hypothyroidism, you should be thinking metabolism. That's the word that should come to your mind. People that are hyperthyroid, they're burning a lot of metabolism. They're anxious, they're sweating, they're very skinny, things like that. Their heart rate's always up, their blood pressure's up, versus hypothyroidism is a slowed metabolism. So they tend to be overweight, tired all the time, cold intolerant, stuff like that. Okay, let's see. And the colloid is in the middle, and you can see these cells lining it over here. Let's see, the parafollicular cells, or C cells, are going to secrete calcitonin. So whenever, so we'll get to it when we talk about PTH, parathyroid hormone comes from the parathyroid. It is going to help to increase your blood calcium levels. Calcitonin works the opposite. It's not super important because we don't actually use it in adults don't use it. It's more prominent in kids when they need to form bone. But it is important to know parafollicular, or C cells, C for calcitonin, that will help to keep the calcium on the bone. It is used in some tumors we're learning about now. You can help to elevate this to prevent the abnormal breakdown of bone. Right, good. There you go, hyperthyroidism. So classically, we talk about Graves' disease, exophthalmos, you get swelling behind the eyes, so the eyes tend to bulge. So what actually happens is this is an autoimmune phenomenon, type 2 hypersensitivity. So you get these anti-TSH antibodies. So they're binding to TSH, and they are causing an excess secretion of thyroid hormone. Okay, so this is a little misleading. And I did look this up a while back. So you would think that with these antibodies activating TSH to be secreted, and it causing an elevated thyroid hormone release, you would think the feedback mechanism would cause a low TSH. So why is it normal? Actually, the literature says that you do get a low TH, a low to normal TSH. But so don't let that trip you up, because if you're having so much, excess thyroid hormone being secreted, yeah, it does feedback and it will decrease it. So don't let that trip you up. But again, you would expect these symptoms of increased metabolism, of course, and also the exophthalmos is classic for this. And then our parathyroid gland, PTH, right? The thing that, when you think of PTH, you're like, oh, it grabs everything off the bone, but that's a last resort for PTH. Ideally, with vitamin D, you're pulling all the calcium you need from the gut, right? And modulating it or titrating it through the kidney. so that everything will work in concert. But in extreme circumstances, PTH can pull calcium off the bone, but it's like if you're severely hypocalcemic. So it is a last-ditch effort, because when you think about it, you're like, you don't really want to be pulling calcium off the bone if you don't have to, right? And making the bones weaker. So it is a last-ditch effort, but we will get into that in a little bit when we do the physiology stuff. But just remember, well, we'll talk about it in a little bit. All right. Pancreas, endocrine and exocrine gland. Endocrine meaning the hormones go to the blood. Exocrine usually means it goes through the duct, right? So it'll go directly into the GI tract. And right, so the endocrine component, the islets of Langerhans, that is going to be where the insulin, the alpha and beta cells, insulin, glucagon are made. So this is kind of a classic picture too. You should commit this to memory. This is the islets of Langerhans, right? So that's where our alpha and beta and delta cells are. So yeah, that's testable for sure. If they could show you this and ask what kind of gland it is, you would say this portion of the pancreas is an endocrine gland, right? Because the insulin and the glucagon go directly to the blood. All right. Now, this is an important point. Diabetes, it translates to like loving. So like diabetes insipidus is like water loving, and diabetes mellitus is sugar loving. So what happens in diabetes insipidus is that you can't concentrate your urine. So for whatever reason, you don't have ADH. Okay, so ADH will help to bring back pure water into the body. So you don't have it, and that therefore you're peeing out dilute urine. You're peeing out excess urine. What y'all should make a note right here. This hyponatremia is in relation to the urine. Okay, so let's make sure, right? Because if you're peeing out pure water, so first off, let's go back. Aldosterone is going to regulate your salt content, right? It'll keep salt. Therefore, you will keep water. When you talk about ADH, salt's not involved. It's pure water channels, right? So you would imagine that if you are peeing out a lot of water, then you won't have a lot of salt in it, right? You're just peeing out pure water, which means your blood will actually be, well, I shouldn't write that because that's going to be confusing, right? So this hyponatremia is in relation to your urine. So what does that mean for the blood? Well, the blood's going to have excess salt in it, right? It's going to be concentrated. It's going to be hyperosmolar, okay, because you're peeing out pure water. Therefore, your body's dehydrated, and all that salt's staying inside. So always peeing, you kind of get thirsty a lot, and then this is in relation to the urine. Now, what happens when we look at this is these patients present the same. Is it a problem with the hypothalamus, or is it sort of like a primary problem, or is it a problem with the actual receptors there? So the only way you could tell the difference is by doing labs, and we'll look at that in a second too. So just make a note that you would expect this. This should make sense to you. If you're peeing out a lot of pure water, you're not going to have a lot of salt, a lot of sodium in it, right? Therefore, in the blood, you would be hypernatremic. You're holding onto the salt, not holding onto the water. All right. And then you know about this now, diabetes mellitus, right? Type 1, you get it when you're younger. Type 2 tends to be insulin resistance versus complete deficiency. All right. Now, and we'll get into those testing in a little bit too. Super important slide here, because they made a point in the lectures to, in all of the lectures, to point out the secondary messenger systems. So it doesn't seem important clinically, but they made an effort to put them all on there. So if you at least remember this part, and know that this goes with CAMP, so it's a GS pathway, then you're good to go. And then, of course, this would be your GQ pathway. Right, so that should make sense. There's a couple of extra, actually, you know what? I think I did something here to make this easier. It's been a while since I looked at this. So yeah, here we go. So this makes it a lot easier. The GS, right, flat champ. So those would be the ones that they would probably ask about. And the GQ pathway, these could be asked as well. And tyrosine kinase, prolactin and GH, and well, insulin should be there too. Insulin works by tyrosine kinase as well. I guess it's technically doesn't fit this profile, but yeah, know that as well. All right, and we've said this a million times. Posterior is just for storing. And let's see, right? Makes sense. The nervous structure of the the axon here will bring the hormones that are made and bring it to the posterior pituitary. All right, and of course, you know, the hormone release has a bunch of different pathways that we use to make it work, but the negative feedback mechanism is by far the most important. Clinical correlates, what was important here? Okay. Tropic hormones are ones that will feed to another organ to release another hormone. Okay, I'll say that again. Tropic means it's going, wait. Yes, all hormones except, yes. Tropic hormones mean it's going to signal to another organ to release it will signal to another organ to release another hormone. So it's a pathway. It's a tropic hormone. It's gonna go, say, from the pituitary to the ovaries or to the adrenal glands or to the thyroid to help the pathway. So to signal another endocrine hormone to be released at that point, right? So these basophils are what classify as tropic hormones. Let's see, give me 1 second. I felt like this was important for some reason. Lindsey, do you remember, they said something about like, if one was injured, I can't remember.
Yes, I remember, hold on, let me look, I'm gonna pull up my, are you talking about the different types of injuries that would injure that thing? Because I know exactly what you're talking about, but it wasn't very high yield.
Sorry, I just got an email. I think this Zoom account maxes out at 100.
I did. I already posted on both of our pages.
Oh, shit. That's an issue. Okay.
I already talked to Will about it. I already posted on the pages. There's nothing we can do.
I mean, if we got a different one, I guess it's too late now.
Yeah.
Okay. Sorry, guys. We had issues. Well, yeah. Well, it's recorded, so it'll be okay.
Yeah. I already told him.
Okay, cool. Yeah, I'm sorry. Yeah, so there was something about
you want the answer to that question?
Yes, please. Sorry, I just checked my phone.
No, you're fine. Hold on. Which lecture was this in?
I have no idea.
Because I have it written down. I know that. Oh, hold on. I found it. I found the lecture. Give me. Okay. Well, maybe I didn't write this down. Clinical correlates, because one area it's if you have like ischemia, one area it's if you have because like there's a first most affected and second most affected because of the placement. I do not remember it being very high yield though. I do not remember it being high yield.
Does anybody remember coming across a question like that? Like if you injured corticotropes, you're likely to injure thyrotropes or something like that? Does that sound familiar?
Not really. I don't remember having like a question like this in our practice, but.
Okay, no worries. Well, just in case, just know like which ones maybe go together. So yeah, no worries. All right, so again, yeah, we talked about those tropic hormones. They're gonna signal to another organ to release a hormone. Like take growth hormone, for example. Why is that not a tropic hormone? Because growth hormone doesn't send, you don't send the growth hormone out to release another hormone per se. It actually helps with the growth. The growth hormone helps with growth in general, right? It's not like TSH, where TSH job is to go to the thyroid and make thyroid release that hormone. So yeah, that's the idea there. All right, so we'll get into some of the hormones, right? Growth hormone, releasing hormone from the hypothalamus, anterior pituitary. Another big one here, somatostatin is going to inhibit the secretion of GH. So that's good to know there. And this is just from first aid. Again, more of the same stuff here. Actually, let's just point out, sorry about that. I usually correlate insulin-like growth factor as like a downstream effect of growth hormone. They kind of have the same principle, right? It just kind of helps with growth. So if that helps you, then awesome. And then of course, growth hormone, like a couple of other things, is secreted in a pulsatile fashion. So that's good to know. And this is the actions of growth hormone. So you can see the growth hormone will act on insulin-like growth factor to help with protein synthesis, cell growth, cartilage, bone growth. That's important, but maybe not intuitively, you do see this anti-insulin activity. So you're gonna break down fat and you're going to increase your blood sugar, whereas insulin would help you to store fat and to store glucose, right? So keep that in mind. It should make sense to you that if you're going to be undergoing processes of growth, you're not storing fat, you're using all this energy to grow the bones and whatnot. You want your blood sugar to be high because you want to be able to utilize that energy to the growth process. So keep in mind if they ask you, it all works together. Like if you forget, just kind of think about it, right? Like you wouldn't want to be storing all this stuff for later. You want to be able to use it, so it needs to be mobile. All right, a little bit of the same, this pathway. Yeah, so wait, I forget why, hold on. Why is this a thing? In hypothyroid children, growth hormone action is impaired. Maybe they work together. I don't know, does anybody know? I don't know.
Oh, thyroid.
I just remember, I remember a question coming up where they had, just so typically, maybe it's not important actually why, but these kids that are hypothyroid, their growth is stunted. So somehow the thyroid hormone, well, I guess it kind of makes sense if you think of that their metabolism is slowed down, so they're not able to mobilize all this energy to increase growth, right? But the question they're going to ask you is, there is a child who has stunted growth, and they're going to give you a couple of other little things, like maybe has like a big bulging tongue, which is classic for hyperthyroid, but you're going to key in on the fact that his growth is stunted, and your first thought is going to be like, well, he's got low growth hormone, right? But it's not, he's actually hypothyroid. So just know that there is this inhibitory action, or even a permissive action of thyroid hormone to act on growth hormone. Okay, so they work together. So if you see these little stunted growth kid questions, don't just jump to lack of GH. It could actually be hypothyroidism. And right, kind of talked about this. Right, so in adults, acromegaly. In kids, it'll be gigantism. Right. So we'll go into this slide. This is always important. This is going to come up again and again. Phenylalanine and tetrahydrobiopterin, or BH4, is going to be the first precursor for these. And tyrosine is the one they ask about. They'll ask you what's the precursor to dopamine. Technically, it's phenylalanine, but they like to talk about tyrosine as well. So you need to know these cofactors. Dopa decarboxylase is right here. That makes dopa to dopamine. B6 is the big cofactor. Dopamine to norepinephrine is vitamin C. And norepinephrine to epinephrine is SAM. Remember, SAM is a methyl transfer, transfers methyl groups. Okay, and then we can go into the other ones, but this is by far the most important. So just make sure you commit these to memory. And here it is again. This just has the enzymes as well with it. So yeah, that's going to be important. Cofactors, know the enzymes. Now you're going to get into this so much when y'all get to neuro. Parkinson's disease. So what ends up happening is you get decreased neurons in the substantia nigra. And those neurons are actually what converts where the dopa decarboxylase is, and converts dopa to dopamine. And if you don't have those neurons over time, then you end up getting Parkinsonian characteristics such as tremors. Later on, you'll get memory issues, mood disturbances, but that's the kind of the process there. You need that tyrosine pathway. All right, and again, what disease did we talk about where you get excess VMA? pheochromocytoma, right? So increased epinephrine or norepinephrine, you would expect to see increased VMA, okay? Pheochromocytoma. And again, remember, these are episodic episodes. So the patient may come in and be feeling fine. You check their urine, there's no increased VMA. They have to be in one of these episodic bursts, right? To be making excess catecholamines to eventually get down to eventually make the VMA or break down the VMA. Right, MAO and COMT, break it down. Remember, serotonin does not fall in the category as a catecholamine, so it only uses MAO, yeah. This is why MAOIs, monoamine oxidase inhibitors, can help with depression to increase your serotonin levels, among other things. All right, and then we go through the tryptophan pathway. Why is this one important? Because this is how you actually make serotonin. So y'all have heard, I'm sure, about serotonin syndrome. Sometimes if you add like SSRIs and or certain medications that increase your serotonin a little bit too much, you get this flushing effect, this hypertension. But what you want to look for in this breakdown of tryptophan to serotonin is if you get serotonin syndrome, this is the byproduct you're looking for. 5-HIAA is what you end up in the urine, and that would be indicative of too much serotonin. But MAO, monoamine oxidase, is going to be what breaks that down. Okay, so definitely keep these enzymes separate in your head. And here we go. Yeah, carcinoid syndrome. So that would be excess serotonin, right? So you would expect to have increased 5-HIAA in the urine. All right, and then we all know about melatonin, right? That helps you sleep, secreted from the pineal gland. It is a byproduct or a breakdown product of serotonin. It's made there, right? So you would expect peaks or spikes of this towards the nighttime. There are, I think it's a neuro concept, there are a lot of like lack of light signals is something indicative that melatonin can be secreted. And then we'll get into this. Why did I put this on here? Oh yeah, that's a good trick. So anytime you have a hydroxylase, is like if we go back and look at these, right? Hydroxylase. A lot of times these use tetrahydrobiopterin or BH4. Okay, not always. This is hydroxylase used in vitamin C, but this is used as a for hydroxylation reactions, right? Okay, I think that's really all that's there. And you can see, as we would expect, from the brain, TRH will go to the pituitary gland to secrete TSH, and then we'll get thyroid hormone formation in the thyroid gland. And of course, T4 is the more active form. When you get it into blood circulation, T3 is more of a storage form, and it can be converted to T4 for activation. So this isn't super important now. When y'all start getting into the drugs in term 4, this is more important because some of the major drug targets help to break these down. But you just need to know that iodine is a super important. You have to have iodine to make thyroid hormone. Use thyroglobulin or TPO, thyroid peroxidase, and you bind the iodine to thyroglobulin, and that helps you to make the thyroid hormone. Remember, if they ask you, thyroid hormone works similarly to steroid hormones. So it is going to go directly through the membrane, and it will go to work directly in the nucleus on the genes, okay? So the actual receptor is in the nucleus, just like the steroid hormones. And goiters, don't let that trip you up. You can actually get a goiter from hyper or hypothyroidism, depending on the type of goiter it is. The most oftentimes, not in the US, but you get a nutritional iodine deficiency. If you get congenital hypothyroidism, remember, this is what's going to throw you off on the exam. Since short stature, don't jump to growth hormone, okay? Intellectual disability, hearing loss is a big one. Seizures. I believe that they have this big beefy tongue. I think I have a picture of it too. Graves' disease, we kind of talked about this, right? There's swelling behind the eyes, and right. Now, when we break down steroid hormones, I know this is a pain. Unfortunately, this is one of the few things you kind of just have to sit there and memorize that table. But when we look at these, and we'll get there in a second, we kind of talked about this already. When you start at the outside, aldosterone and mineralocorticoids, then you go to cortisol or the glucocorticoids, and the deepest part is these androgens. And then they will act downstream on the testes or the ovaries. So you would consider all of these tropic hormones, right? Because they are a hormone that's going to work downstream on another hormone, okay? And we kind of talked about this already. Aldosterone, there is a little bit of ACTH there, but if they ask you, aldosterone works with angiotensin too, whereas cortisol is going to be dealing with ACTH. And then, of course, the sex hormones are in the lowest layer. Why is this important? Okay, yeah, the STAR thing, I don't know that this came up, but this is going to be the regulated steps. So this is what's going to get that cholesterol, that precursor to making all of these adrenal hormones. You're going to use STAR to get it across into the mitochondria. So if they ask that, that's going to be the important enzyme there. Now, we've talked about this at length, but it's such a super important concept, this idea of in this RAS system. So if the body recognizes that you don't have enough blood volume or your blood pressure is down, it's going to release renin. Renin's going to do two things. It's going to release angiotensin, or the angiotensin process, to eventually get to angiotensin 2. Angiotensin tenses down on the vessels. That intrinsically will raise the blood pressure. Also, it's going to release aldosterone, right? Because if you have low blood pressure, you want to bring back more fluid, right? So aldosterone is going to help pull salt back. It's going to pull water back. So it's going to increase your fluid. So this process has a twofold effect. You're clamping down on the vessels, you're bringing more water in. Both concepts are going to help to increase your blood pressure. All right, cortisol is one of those weird things. This kind of just doesn't make sense. I mean, like, I don't know. It does a lot of weird things, in my opinion. So it's going to help with gluconeogenesis and glucose control. But if you have Cushing's disease, right, you're going to tend to have increased blood glucose. Okay, so people with Cushing's, they tend to end up with diabetes. Now, you're also going to work on breaking down adipose tissue, but it's weird though, because when you talk about Cushing's, you talk about that buffalo hump. So the adipose tissue is broken down, but it's redistributed. And we may have a picture for it, but they have those a large, like the fat is redistributed to their abdomen and that buffalo hump. So just because you're breaking it down, it actually gets just redistributed in the body incorrectly. And then you're going to get protein degradation, which is never good in a massive sense like that with hypercortisolism. And then, of course, it has anti-inflammatory processes, which, again, if you have Cushing's disease and it's too much cortisol, you can be your immune system is compromised at that point. Okay, some enzymes you need to know. Aromatase, definitely know both. CYP19 correlates to aromatase. That's going to help you to make estrogen. That one's more important than this one over here, but 17 beta hydroxysteroid DH3 is going to help to make testosterone. Yeah, and right, DHEA is going to be the precursor to help to make estrogen and testosterone. And we remember the more potent form of testosterone is DHT, which will be another process from, I'm sure it's going to come up in a little bit. This is going to be in your Leydig cells that this happens. Remember, Leydig is going to help to make the fully formed testosterone. All right, so abnormal cortisol synthesis. So when we talk about this in kids, we have this congenital adrenal hyperplasia. When we talk about 21 hydroxylase, 17 or 11, which we have a trick for that, how to remember those. But the cortisol synthesis is reduced in all of them. But the other factors, depending on which enzyme is deficient, will help to determine which exactly it is. And we'll show you that in a second. Addison's disease is atrophy of the whole adrenal cortex. So everything is deficient. And we'll look at that in a second too, because this is a super important concept. You usually get that, it's an acquired saying you don't get it from birth like the CAHs. So it can happen in your 20s or 30s, but you get this full-blown atrophy of all those cells. And then, of course, if you have cortisol increase, you end up with Cushing syndrome, right? So it could be a tumor, depending on where it is, will help to determine the severity of it, right? Keep in mind, syndrome is related to the adrenal gland. Disease is from the pituitary gland. Why it's like that, I don't really know, but that's what they decided to name it. So you need to keep those separate because they could ask you, there's a tumor in the pituitary, and you would want to say that would be Cushing's disease, not syndrome. Okay, so if you're in doubt and you really don't know the answer, always go with 21. That's the most common one. That's the one that's most commonly tested if they ask, but it could be these. So we do have a trick to knowing this. Remember, in all of them, they have decreased cortisol in all of them. So we're going to break this down. Unfortunately, this is one of those charts that may be good to know this pathway because they could kind of tag these and bring it up. But again, we're going to look at the clinical correlates right here, and we'll talk about how to do it a trick way. So if there is a 1, so the first column, when we talk about 21 or 17 or 11, so the first number is going to correlate to blood pressure. If there's a 1 in that column, in the blood pressure column, that means the patient's going to have increased blood pressure, right? So something is feeding forward to aldosterone and causing a spike in their blood pressure. If there is no 1 in the column, then it doesn't correlate. So someone with 17 hydroxylase deficiency will have increased blood pressure, but not increased androgens, okay? Now for 21, we do the same thing. Blood pressure here, no, so they don't have increased blood pressure, but they do have increased androgens because there's a 1 in the second column. So you should be able to ask yourself, how does this kid present? So kid comes in, his blood pressure is 80/60, okay? So, all right, so the blood pressure is low. He's not actively making aldosterone to bring his blood pressure up. So no 1 in this column. But, and usually they'll use a female for this because if you have increased androgens, you're gonna have increased testosterone, increased masculinization. So if that's the case, it's hard to recognize in a boy if you have increased androgens, right? But in a female, her sexual characteristics will be more masculinized. So they'll typically say a little girl comes in, her blood pressure is 80/60, and she has ambiguous genitalia, meaning it has male characteristics to it. It's kind of hard to tell what's going on. So they'll have a 1 in this column, and then immediately you can say, okay, perfect, low and then high. So it's 21. And 11 has a 1 in each column. So you'd expect increased blood pressure and increased androgens. Now, so this is the slide. This will help you remember what goes with what. Again, a 1 in each column correlates with an increase in these. So you should be able to say what is going on with increased blood pressure. It's an aldosterone issue. What is going on with increased androgens, increased DHEA, increased testosterone, okay? Now, what I want to show you, because you may have come across this, let's look at this increased blood pressure here real quick, because it's actually a mild increase in blood pressure, but it is increased. But if we go back, this is, so this enzyme is what is deficient here. And you may say, well, if you're not actually fully forming aldosterone, why is the blood pressure increased? Well, as it stands, this right here is a mild mineralocorticoid. So it actually can, even though you're not fully forming aldosterone, this can cause an increase in blood pressure in itself. So I don't know that they really tell you that. I looked it up to see, but that's what it is. So it'll cause a mild increase in blood pressure, which is why these kids have that. Okay. And then here's the full, this is a better one. So yeah, so look, this is where you have this 11 beta hydroxylase deficiency. So you're not making these. So you get an increase in 11 deoxycorticosterone, and this can act to increase your blood pressure, a mild mineralocorticoid. Okay, another trick, this is actually super important. I don't think I wrote it in here. right here, this is definitively diagnostic for 21 hydroxylase deficiency. So this is our enzyme that's deficient. If they'll tell you in the stem, the patient has an increase in 17 hydroxyprogesterone in their urine. Immediately, you know that this is 21 hydroxylase deficiency. Why? Because this enzyme is not there, it's not working. So you can't break down 17 hydroxyprogesterone to fully form cortisol. Okay, so if they ever say that, which they will, that is diagnostic for 21 hydroxylase deficiency, always. All right, again, oh, here, this is where, yeah, so that's a good point here. 11-deoxycorticosterone is a mild mineralocorticoid. That's why these 11-beta hydroxylase deficiency kids do have increase in blood pressure. And this is a nice chart table. If you like that kind of thing, go for it. Now we'll look at the sex hormones, right? So ask yourself, are these tropic hormones? Well, yeah, because these are going to come from the pituitary and they're going to go down to the ovaries or the kidneys, I'm sorry, or the testicles, and they're going to cause another secretion of hormones, right? So there. So GnRH is going to come from the hypothalamus, go to the anterior pituitary. You'll release LH and FSH, and that will help to go through the process. So here we're talking about the testes. LH, L for Leydig, that's just a good way to remember it, will help to form testosterone. FSH, it's easier in females because you think follicle, right? It helps to develop the follicle, but it also in males will help to develop the sperm as well, okay? And you can see this very super important enzyme here, 5-alpha reductase. You need that to convert testosterone to the more potent DHT. Okay. Let's see. Yeah. Good. All right. And then we go to the females, and LH is going to help to make testosterone, which is the precursor to estrogen, or the estrogen is broken down into different forms. Estradiol is the most potent form of it, the most used. So with this process, you will form estradiol and again, the follicle stimulating hormone will be that final process. So just remember, it kind of goes around. The Leydig is going to help, sorry, not Leydig, the LH is going to go to the theca cells and help to make testosterone, and then it'll fully form the estradiol in the granulosa cells, okay? And very importantly, this is going to contain aromatase. What's aromatase going to do, or also known as CYP19, that's going to form the fully formed estradiol. All right, now, yeah, we talked about this a little bit, so let's go into this a little. So we did these already. Let's talk about Addison's disease. Now, again, this is an acquired problem, some sort of infection or something comes around, and all of the cells of the adrenal cortex get destroyed. So you get a lot of issues here, but these patients are classic when they come in. There's only a few situations that look like this. So this in hemochromatosis, I don't know if y'all got to that yet, but these patients end up being brown, right, or bronze, and there's a reason for that. So what actually happens is, so think about it. If all of the adrenal gland hormones are gone, like you can't secrete them, what's the pituitary going to do? It's constantly sensing that we need more adrenal gland hormones to be released, but they're not there. So what's going to happen is your ACTH is always going to be elevated. It's like, please make more cortisol. You can't, right? There's no cells there to make cortisol. So ACTH will be chronically elevated in these people. Now, ACTH breaks down, or excuse me, not ACTH. The precursor to ACTH is POMC, right? And it actually breaks down to ACTH, but it also breaks down to MSH. So these melanocyte stimulating hormones will help you to make melanin. So if you constantly have to make ACTH, you're constantly making the precursor POMC, so you're indirectly making increased MSH. So if you're doing this, you're going to end up bronze like this, right? Because this is going to deposit, you're going to get increased melanin, so you're going to get increased color of the skin. Now, there are also some other things that are important here, but the bronze pigmentation is by far going to be the most important, and lab values, increased ACTH is going to be what you're looking for there. All right, now we said this again, disease correlates to the pituitary, syndrome correlates to the adrenal gland. Now, what does this mean when the patients come in, right? They're going to present the same. They're going to have these Cushionoid features, right? The buffalo hump, the moon facies, the abdominal striae, right? The redistribution of fat, hyperglycemia, right? Because cortisol, increased cortisol will cause your blood glucose to go up, so they could be diabetic. So these are classic symptoms for these Cushing's patients. But what do you need to do? You need to be able to differentiate. Is this coming from the adrenal gland or is it coming from the pituitary? Now, if it's primary and it's coming from the adrenal gland, you would expect a low ACTH, right? Because the adrenal gland would be making, maybe it's a tumor or something, increased cortisol, right? Yeah, wrong with my mouse. That's good. Cortisol. Right. So it's going to feed back to the pituitary and it's going to cause low ACTH. Now here, this is secondary. This may be, say, a tumor in the pituitary. So it has high ACTH. So this is going to be the problem that's causing the increased cortisol, right? So either way you look at it, you just need to be able to differentiate. Is it coming from the pituitary? Or is it coming from the adrenal gland? Is it primary or is it secondary? Cool. Let's see. Yeah. So again, adrenal adenomas, this would be a primary cause. Pituitary tumor, this would be a secondary cause. Right. Yeah. So over time, I mean, right. So the increased medications can cause these features. What actually happens if they get off these medications? They get a drastic decrease because his body's never really made it. If you're taking a medication, your body doesn't have to make it, so those cells atrophy and die. But what they're saying here is that if you take too many corticosteroids for a long time, you will get Cushionoid features. That's why corticosteroid treatment is reserved for short-term care. Now, again, we look at these are classic, the buffalo hump. You're breaking down fat, but you're redistributing it. You see these abdominal striae, you see large abdomen like this, round facies, hirsutism, which is hair. You can see this, why are the arms and legs thin? Because you're breaking down protein. Of course, they can coexist with diabetes, right? Because they have elevated blood glucose. So you're constantly stimulating the pancreas to make more insulin, and you burn it out. And of course, if cortisol has an effect on decreasing the inflammatory process, you could be at risk for certain different pathogens if your immune system isn't developed enough. All right, so you can get situations where the whole, you get decrease or cell loss in the whole pituitary, and it would be as you expected, right? A decrease in all of these hormones coming from the pituitary, and likely an increase in the hormones coming from the brain, right? Because they're trying to stimulate it, but there's nothing there to stimulate. Now, a good point. Oh yeah, okay. So this is a good point to make. They'll ask you about the pituitary stalk. Okay, so this stalk is where dopamine can come from the brain and get into the pituitary and help to inhibit prolactin. So if this stalk is not working, dopamine can't get to the cells, to those lactotropes, to decrease prolactin, so you'll get hyperprolactinemia. So again, it's a good test question, right? It's something kind of off the wall, but they're testing the fact that dopamine is an inhibitor of those lactotropes. So if you can't get it there, a stalk injury, then you'll get hyperprolactinemia. GH deficiency, of course, you would imagine dwarfism. Yeah. Prolactin, right? No, not ejection. We develop. Remember, oxytocin is going to be what ejects milk. Prolactin is going to help make the milk and growth of the glands of the breast. Yeah, so this should make sense, right? If you're making prolactin, that you should be pregnant, right? So if you're pregnant and making prolactin, you shouldn't be ovulating. You can't. There's no point ovulating if you have you know, if you're pregnant. So it will help to feed back to suppress GnRH. Okay, so if you had some sort of reason that you have hyperprolactinemia, let's take the last case right here. Right, let's say you have a dopamine stalk injury. Okay, so you get hyperprolactinemia. You probably won't have regular, you know, menstrual cycles, right? Because if you have excess prolactin, it's going to feed back to GnRH and help and block it. So the complaints may be like, I have, you know, I'm lactating, I don't, you know, I'm not pregnant. What's the deal? And my menstrual cycles are irregular. So, you know, keep that in mind, that those kind of go together. And you can see that here. So, oh, this is another, sorry, this is another a little more in-depth thing I wanted to add here. So let's take this situation. Let's take a patient, let's say a female, middle-aged, she has hypothyroidism. So she's not making thyroid hormones. So TRH from the pituitary is going to be elevated, right? Because it's trying to tell the thyroid, the thyroid gland to make more thyroid hormone, but it can't. So remember, we said that TRH also has the effect of stimulating prolactin secretion. Okay, well, if you have excess prolactin or hyperprolactinemia, you're also going to get inhibition here of GnRH. You get inhibition of GnRH, then you're going to get anovulatory cycles, right? Because GnRH has to feed forward to LH and FSH. And if you can't do that, your cycles will be off. All right. Remember, we said in regards to prolactin here, this is the same thing as prolactin inhibitory factor is synonymous for dopamine. So that's definitely good to know. Again, we just wanted to point out that TRH is going to help to stimulate prolactin secretion. Prolactinoma, right, you can see here, I believe that's the most common type of primary brain tumor in the pituitary. Don't quote me on that, but I think so. But what's important here, you'll learn in neuro that this optic chiasm here with the optic nerve will run there. So sometimes the first sign of a prolactinoma is vision changes that you can see. So that's common anytime somebody has, it's just, you'll learn about it. It's called bitemporal hemianopsy. You can't see outside of your eyes, both sides. So the patient complains with that, you know, you immediately want to get some sort of MRI to see if there's a growth in the pituitary gland. Yeah, y'all will get into that later, but if it comes up, that's what they're referring to. Posterior pituitary, right? So SADPOX, ADH is going to be secreted, and we'll get into some of the problems with it right now, apparently. All right, so two different types. How are these patients going to present? Exactly the same, right? They're always thirsty. They're peeing a lot, they, you know, even though they're drinking a lot, they constantly feel dehydrated. So if it is a primary problem, so how do you determine it's primary or secondary? Well, what is the problem in diabetes insipidus? Well, the problem is ADH, right? Where does ADH come from? Well, it comes from the posterior pituitary. So the posterior pituitary correlates to the primary problem. The nephrogenic is going to be secondary because that's a receptor problem downstream. So what do you do when this patient comes in? Well, you have to check and see if the levels of ADH are up or down. And that's going to correlate to if it's a problem in the pituitary or a problem downstream at the receptors. So there's a test we'll look at that you actually do. But, oops, clear. There we go. And just to note, remember these V2 receptors are those aquaporons. Those are what binds ADH. There's no salt involved here. That's aldosterone. ADH works with pure water. So these are pure water channels. So definitely keep that in mind. All right, so this is what you do. When the patient comes in, what does this mean? Remember, we talked about osmolarity. If you see the word osmolarity, that means there is stuff, right? High osmolarity means there's a lot of stuff in it. There's a lot of particles in it, right? So if the urine has a high osmolarity, it's very concentrated. There's a lot of stuff in it. If the urine has a low osmolarity, it's very dilute. There's not a lot of stuff in it, right? So here you see these patients have very dilute urine, right? They're peeing out a lot of free water. That's an issue. So what do? You give them ADH. So if it's a primary problem, you know, that means the pituitary is not making ADH. So if you give them exogenous ADH, well, it corrects it, right? All of a sudden, you're holding on to more water and your urine osmolarity goes up, so it's more concentrated. But if it's a secondary problem in the kidney, nephrogenic, yeah, and you give ADH, it doesn't matter because it's the receptors that are the problem. Okay. All right. Now this also works in reverse. So diabetes insipidus. What if you have syndrome of inappropriate ADH? What does that mean? Or antidiuretic hormone. So these people are holding on to a lot of water. They're not getting rid of it. What does that mean? Well, their urine's going to be very concentrated, right? Because if they're holding on to all this extra free water, water retention, increased urinary concentration. What did we say osmolarity meant? Stuff. Well, it's decreased because they're holding on to all that free water. So it's very dilute blood. Okay, so you can give an ADH antagonist, and that will help to demeclocycline, and that'll help to block the ADH channels. And it's not important, but yeah, it'll block those ADH channels so that you can you can dilute your urine. Okay, so right, I think that's all for. Oh, sorry. They're commonly they don't call this oat cell cancer. It's small cell cancer of the lung. This is like an old term for it, but a lot of times, and y'all will get into this later, but these small cell tumors in the lung will actually cause ADH to be secreted from them. It's just coincidental that the structure looks just like ADH that's secreted from these tumors. And so they actually secrete it. So if you go and you look and you're like, I don't see a problem in the pituitary secreting ADH, the kidneys, the receptors work, you might want to look for a tumor, specifically, classically, these tumors in the lung. So yeah. Right, and then of course there's oxytocin. When you think of oxytocin, we're squeezing down on muscles and stuff like that. So when during birth, if you get an increase in oxytocin, it'll squeeze down on the endometrium, the myometrium, and the baby can be delivered. Also, after that, it'll help to squeeze down, and it will help to decrease the blood flow after the birth. And so you don't have postpartum hemorrhage. It'll also help to release milk from the breast for breastfeeding. Remember, one of the important things about oxytocin, it uses a feed forward mechanism versus a feedback mechanism, where most of the hormones go a feedback, where when the terminal hormone is made, it can feed back to the precursor and slow it down. But this oxytocin, if it's secreted, it's telling it to keep secreting. It's like, we're doing this. We're delivering this baby right now, right? So if you get some oxytocin, it'll feed forward, so you keep making it until everything is said and done. All right, cool. I love Dr. Trotz. We'll take a little break right here, maybe 5 minutes. How's that sound? Cool?
Sounds good.
All right, cool. All right, are we good? I think we're good. Adrenal glands. Now, we kind of talked about this already. Remember, depending where you read, again, ACTH kind of works here too, but for testing purposes, aldosterone, the RAS system, ACTH, cortisol, and then once you get that, and technically it works with the sex hormones too, ACTH. And then of course, once you get down to the medulla, sympathetic control, if they give you a histo picture, which they probably will, remember that fasciculata layer is pretty thick. All right. So right, we know cortisol is a stress hormone. And typically, if you're like me, you're more stressed out when you have to wake up in the morning. So that's how I remember that. Your cortisol levels are typically elevated in the morning when it's late at night and you're Netflixing. You're good, right? That's how I remember it. All right. What are we doing here? Right, this is, again, we kind of talked about this POMC. It makes ACTH, but it also makes MSH. And if you have a situation like Addison's disease, where you have chronic ACTH production because you can't make cortisol, you're going to subsequently make MSH. Therefore, that's why they get the bronzing of the skin. So definitely keep that in mind. They'll put that on the test. There you go, Addison's disease. All right, and we don't have to go through this again, but we know the renin system, the whole point of it is if the body recognizes low blood pressure, it's going to stimulate the RAS system. Actually, I had the pleasure of going through one of your questions last night, and I want to show y'all something because this is pretty, I don't know if it was super intuitive, but the question said that if you had renal artery stenosis, right? The patient came in, renal artery stenosis, And she had severe edema, right? Her blood pressure was up, all this stuff. Let me show you what actually happens in this situation. So if the blood's coming in here and you get to this point where there's a constriction, over here, you'll get hypertension. But once you get to the other side, you get hypotension, right? Just in this little area, not throughout the body, but just because of this renal artery stenosis, you'll get it there. Now, as it happens, these JGA cells are right here. So they're constantly feeling this hypotension, even though the body's, it's just this little area. So what's it gonna do in response? Well, it's gonna be like, oh my goodness, we don't have a lot of blood. We don't have a lot of blood volume. So it's gonna wanna secrete renin, bring up the blood. So what's gonna end up happening is this chronic secretion of the RAS system, just because the body's stimulating this. So aldosterone is going to be the problem when we talk about this, because the patient is edematous or has a lot of edema and high blood pressure. So that's what happens whenever you get renal artery stenosis. You want to think about the idea that a little bit downstream from that stenosis is where those cells are that recognize the blood pressure. So that's something to take note of. Right, okay, cool. And then of course, if you have hypertension, there's no point in secreting this stuff. You don't wanna do that. You wanna pee out more sodium, so you pee out more water. All right, hyperaldosteronism, Cone syndrome. Yeah, that's it. Now, again, these are great test questions because these patients present exactly the same with primary or secondary. The question you need to ask is, well, what's going on? Is it a primary problem coming from the adrenal gland, or is it a secondary problem? Okay, so what do? You check for some lab values. If it is a adrenal adenoma secreting aldosterone, you would expect the normal feedback mechanism to decrease renin, right? Because it's a primary problem. The aldosterone is being secreted, so it's going to feed back. Now, if it's a secondary problem, the problem is the secretion of renin, so it's going to be elevated. So again, like I was just saying, if you had something like renal artery stenosis, that's going to have this overactivation. Oh, here it is. Renal artery stenosis, that's going to have that overactivation of the JGA cells. So that's going to activate RAS. So again, they're going to ask you this kind of stuff. Is it primary? Or is it secondary? Where is it coming from? Check the lab values. They're going to be flipped. All right. Do we want to do this? Right. So now, this is like that. This is more of a renal thing, but we'll just go ahead and go through it. So what happens is if you have hyperaldosteronism, now, of course, you want to ask yourself, are we talking about the blood or are we talking about the urine? So let's take the blood, for example. If you have increased aldosterone, you're going to have increased sodium reuptake, right? And that's going to make you bring the water. So you're going to have hypernatremia. Now, remember, there's always a consequence to that because the potassium it's a countercurrent exchanger, or that sodium potassium pump. So potassium is going to be lost in the urine. So in the blood, you're going to get increased sodium and decreased potassium. But if you were to check the urine, you would have like hyponatremia and hyperkalemia. But let's not confuse it. Let's just talk about the blood. So again, aldosterone is going to bring back sodium. So you have hypernatremia, and you're going to kick out potassium. So your blood is going to be hypokalemic. Okay. Now, remember, we talked about this. This was called this paradoxical aciduria, where you get metabolic alkalosis, and I'll show you why. What actually happens is at the terminal end of the collecting tubule, you have these potassium, hydrogen potassium antiporters. Okay, so the body's sensing, like, even though you have all this aldosterone and you're kicking out all this potassium, the body's sensing that it needs to try to keep the potassium. So in an effort to do that, it's going to get rid of hydrogens. Okay, and by doing that, you're still going to be hypokalemic, your body, but at least you're saving a little bit of the potassium. But at the consequences, you're going to kick out these hydrogens. So Of course, what that's going to mean is you're going to have metabolic alkalosis because hydrogen acts as an acid. So that's why they end up with alkalosis. It's just a last-ditch effort to try to do that. As for the intracellular versus extracellular, that's not super important. The point is like, what is it going to be clinically? So just keep an eye on that. And of course, we would expect decreased renin in primary because the problem is actually say a tumor in the adrenal gland that's causing causing a secretion of aldosterone. Okay, again, starred slide. This is what we're looking at. We're talking about it again. If the aldosterone is what is elevated primarily from the adrenal gland, you will get a negative feedback of renin. If the problem is with the JGA cells or maybe renal artery stenosis, you will get increased renin, and that will feed to the aldosterone to be increased as well. Okay, and this is what we just said, right? So, oh, sorry, no, this is the opposite, right? So hypoaldosteronism. So now we are not able to hold on to the sodium, right? So we're peeing out a lot of water. So what are these patients' blood pressures going to be? Really low, right? They're not able to bring back the sodium. They're not able to bring back the water. What's an example? The CAH, the congenital adrenal gland or adrenal hyperplasia that has hypoaldosteronism. Remember that first column is high blood pressure. So this would be low blood pressure. So this would be like 21 hydroxylase. Those kids with 21 hydroxylase have low blood pressure and increased androgens. Okay, so make sure that you could use those one columns for that, right? So, so you would expect anybody with hypoaldosteronism to have a low blood pressure. So again, your blood is going to have, let's use blood again. Your blood is going to have decreased sodium because the aldosterone can't keep it in. So therefore, you're going to pee out a lot of free water too, or a lot of water with the sodium. So that means you'll be very dehydrated, okay? And then the blood will also have increased potassium, hyperkalemia, okay? Good. And cool, so we get to medulla. Remember, pheochromocytoma is the main part that the main tumor that they test on there. Regulated by the sympathetic nervous system. Where do these cells, what are the precursors to these cells? Remember, neurocrest cells, right? There you go. And there was something important here. Oh yeah, that last enzyme that converts norepinephrine to epinephrine, remember they use SAM as the cofactor, PNMT. Cortisol could actually upregulate PNMT. I guess there was a practice question that brought this up. And that's why I felt that's the need to put this on here. So there's a synergy between cortisol and the ability to make epinephrine as well. All right. So when you think of catecholamines, you're thinking fight or flight. You're thinking you're running away from a bear, right? So of course you want all the energy you could find. So you break down fats, you make as much glucose as you can, right? So you're breaking down glycogen to bring up your blood pressure. Again, yeah, wherever you can, just to mobilize your glucose in your blood, so you get that fight or flight response. And there's a twofold effect here when you talk about stress. Remember, the immediate effect is going to be of stress is going to be from your catecholamines, right? If you're stressed out, you know, epinephrine's up, you feel anxious. But the long-term effect is that increase in cortisol. So that is a delayed effect. It takes time. So to chronic stress, increase cortisol levels, and you can get complications from that. This just kind of goes into that. Again, short-term response, you would think those catecholamine type effects versus long-term, where you get protein breakdown and fat redistribution and stuff like that, and immune suppression, very importantly. All right, get into the thyroid. Right, and we know this, right? We did this already. TSH is going to go to the thyroid gland to make thyroid hormone. We talked about this. T4 is the main one, the strong one that you're going to use. That's what you need to focus on. Again, I don't want to dive too far into this. Once y'all start doing the drugs like propylthiouracil works on this iodination process. The main thing you need to know, TPO is the enzyme, thyroid peroxidase, that's what you're going to do. The whole point is to bring in iodine. It was I forget, secondary active transport, I believe. Yeah, so you bring in iodine and then it'll attach to thyroglobulin, depending on if you add two iodines to it, you can get MIT or DIT. That's not super important. And yeah, oh, here's the pump. Well, I'm sorry. Okay, let's do it this way. So this is the blood over here. So it's coming through this way. You see this iodine, sodium, or sodium iodine symporter coming in. So secondary active transport, bring in iodine. You can cross it over into the follicle, and then you can attach it to thyroglobulin with thyroid peroxidase. Iodination is the process of adding iodine, then you conjugate it, right? And then it can be brought back in and then kicked back into the blood. All right, this is just from first aid, same thing. And that's what we talk about in term 4, or we did talk about term 4. PTU and methimazole, they work on blocking this process. So if you can't form this complex, you're not going to be able to have active T4 in the blood. And so you use that to treat people with hyperthyroidism. Right, and again, when you think of the thyroid gland, you want to think about metabolism. This is a good one from first aid, the 7 B's, so this is going to be the process. But again, you're thinking about increase in metabolism. So this is all going to be the process. Metabolic rate, basal metabolic rate goes up. Blood sugar, you're going to want that to go up. You're breaking down lipids, so you have more energy available. Beta adrenergic or adrenergic in general effects, right? So remember beta 1, so 1 heart, beta 2 is lungs, 2 lungs. So beta 1 is for the heart, beta 2 is for the lungs. So you're going to get beta adrenergic effects, increased heart rate, stuff like that. And here you can see, remember we were talking about the idea of those little hypothyroid children that have stunted growth. If you're hyperthyroid, it has a synergism with growth hormone, so you can get increased growth. But the classic question they ask is kids that are hypothyroid, how they have stunted growth. All right, and then for the most part, we're talking about catabolism. Catabolism meaning breakdown, but it does have this effect here of anabolism or building, which is, you can see there is increased protein synthesis. And overall, I mean, you do get protein breakdown, but the overall process is that, you know, once you mobilize it, you can start building precursors and building protein. So this is just an overall summation of things, but it's one of those things that sticks out. It's different than everything else. So I guess technically it could be tested, right? So yeah, mostly breakdown, but you get an anabolic effect on the proteins. Yeah, super important. You want to know this enzyme. Why is it going this way? Somebody check me. Doesn't it? Well, I get. Is it bidirectional? I thought it went from T3 to T4. What are we doing here? Maybe yes, maybe no.
T4 to T3 because T3 is active.
I thought T4 was the most active one.
T3.
I
Googled it, Brady.
I'm sorry. Okay, if you say so. Sure. So 5-deodoinase will help that conversion. Remember that thyroid hormone acts like a steroid hormone. It goes directly to the nucleus for to modulate gene expression. Okay. So we talked about Graves' disease. Remember, those are autoantibodies, type 2 hypersensitivity. These antibodies attach to the TSH receptor and cause a downstream upregulation of thyroid hormone. And then Hashimoto's disease is a hypothyroidism, right? So you're actually blocking this effect. So these patients are hypothyroid. Either way, you get a goiter, whether it's hyper or hypo in these situations. So don't use that as a diagnostic clue. And yeah, that's the big thing. So like, if there's some reason, they talk about this theoretically, like if there was a radioactive attack, like some sort of nuclear attack, if you ingest a lot of like iodine, like salt, you know, salt is in the States is iodinated so that you keep your salt levels up. If you ingest a lot of it, since like most of like 99% of your iodine is stored in your thyroid, you can try to like fill it up, like so you have all your stores, so that if the radioactive iodine hits you, like it won't be stored. So that's like a whole concept that, you know, like if there's a scare of a nuclear attack overseas or whatever, people go buy all kind of iodine supplements and stuff. So, and again, hyperthyroidism, we're talking about increased metabolism. So this is what we're going to talk about. Why are we getting amenorrhea or anovulatory cycles for whatnot? Remember, because we said that this thyroid hormone is going to have an effect on prolactin. Prolactin is going to feed to that GnRH, and that GnRH is going to be problematic for normal menstrual cycles, right? But the whole overall goal here is increased metabolism. We talked about Graves. We're good there. Pre-tibial mixed edema, if you're ever wondering what that is, it's just a form of non-pitting edema. So this, these are these autoantibodies. So we talked about that. Now, hypothyroidism is a decrease in thyroid hormones. Like we said, Hashimoto's thyroiditis is there. Classically, it's just a nutritional deficiency of iodine. Right. Yeah, and you would expect this stuff that looks like their metabolism is slowed down. All right, insulin and glucagon. So we know that with endogenous insulin, there's always C-peptide. So if you're trying to check if somebody has an increase in endogenous insulin versus like if they're injecting it exogenous, you can always check the C-peptide levels. The question they always ask is like they found a nurse who was passed out, and they thought maybe she was her insulin levels were up because you know you can inject insulin to help to decrease your blood glucose and stuff like that. So people do it, and you could check to see if they use nurses just because they have access to it. You could check to see if the C-peptide level is elevated, because if it's not, that means it was being injected. But that's just a question that comes up on board exam questions, right? And you could see this, right? C-peptide would be high. And yeah, I mean, this is more, y'all are going to get into this in with DM, like an insane amount. But you know, after meals, you secrete insulin so that you could store it. You can get all the blood glucose out of the blood and store it. And then glucagon is the opposite. If you're hypoglycemic or if in a fasting state, it helps to mobilize those stores to increase your blood glucose. So endocrine pancreas, different color staining here, but that's the islets of Langerhans that you would expect. So that is going to be endocrine, right? Because insulin, glucagon gets directly released into the blood. All right, beta alpha, beta is insulin, alpha is glucagon, delta somatostatin. Yeah, so it has an inhibitory effect. What else did we talk? So this is interesting. So this is a different area of somatostatin, because you may remember that it inhibits growth hormone, if you remember that too. But it's actually made in a couple different places in the body. So this one, it will help to inhibit the release of insulin and glucagon. And if you're wondering like why would you try to inhibit both? The idea is that it actually slows down your GI motility as well. So it helps to like let the food sit in the stomach and kind of churn and break down before you start metabolizing things. So y'all will get into that a little later too, but that's how that works. And right, so yeah, so of course, you know, elevated, you know, when you get secretion from the beta cells of insulin, your blood glucose is going to be the main thing. These aren't super important right now. Y'all will get into this later. Inhibitory process. You don't want insulin. You don't want, when you're running from a bear, norepinephrine, epinephrine, you don't want to be storing stuff. You want to have all the blood glucose, all the sugar you need in your blood so you could run really fast. And somatostatin, like we said, also has an inhibitory effect. All right, yeah, so we know this, GLUT4 is insulin dependent, right? So if you're gonna upregulate or get insulin into the muscles specifically, you gotta use GLUT4. If you wanna get glucose into the muscles, yeah, you need insulin there, which makes sense because if you have high blood glucose, your insulin's gonna be released. Insulin will tell the muscles to just pull that glucose out of circulation and give it to the muscles. Right. Liver's going to store it. We talked about GLUT4. So liver uses the GLUT2. GLUT4 is for the muscles, right? Again, insulin dependent. Fat cells, of course, with insulin, you're going to store the excess sugar as tags, which are fat. But yeah, again, y'all are going to get into this a lot more later. Glucagon's the opposite. So if you have low blood glucose, you can secrete this and it'll help to bring it up. You see this here. Increase in blood glucose. If you have a high blood glucose, you're not trying to put more in the blood, right? So that's inhibitory. Insulin works together with increased blood glucose to pull the sugar out of the blood. And again, somatostatin is going to inhibit both. Right. For some reason, Dr. Trotz made a point that this is very important. You actually have glucagon receptors, not only in the hepatocytes where you would expect, but also in the renal cortex cells. So that's definitely, I feel like that was a test question. And then postprandials, right after you eat. So you would expect the glucose levels to be elevated. And that's when you secrete insulin, starvation, glucagon, right? Fasting, yeah, 70 to 110, right about 100, you're good. 2 hours postprandial, you wouldn't want it to be above 120. Now, y'all learned, yeah, they usually use a hemoglobin H1C because you get a longer time span, like a 3-month window of what the patient's glucose was. Anything below 55, that's a good point to be made. You get into the, well, kind of like the oh no phase, right? You're like getting to the point where you're starting to feel it, like you're starting to sweat, your heart rate's going up, and that's because you're starting to release catecholamines, right? And yeah, neural symptoms. So you're starting to shake, you get tremors and stuff like that. So it's about 55 is the point. And let's see. Yeah, I mean, this makes sense. Of course, the brain always needs glucose. You know, worst case, you can go into ketogenesis. Again, y'all are going to talk about this a lot more. That's why I don't want to get into too much detail. Red blood cells need glucose available too. They don't have mitochondria. They're not making a lot of ATP, so they need it available for glycolysis. Yeah, and again, this is when you're like really getting into the below 55 phase. And you're trying to bring things up at that point. Yep, same thing. 70, you're getting you're starting to release more likely glucagon, right? And these three tend to go together, right? Glucagon, growth hormone, cortisol, all of them are going to act to increase your blood glucose. As you get a little bit lower to 55, you get those adrenergic response. So a lot more epinephrine, and you're starting to shake and stuff like that. Again, here you go. So symptoms of these adrenergic: anxiety, palpitations, tremor, sweating, neuroglycopenic symptoms, right? So you get this gradual decline, but once you get below 40, then you're starting to get, so, your brain is deprived of glucose. You can go into a coma. All right, so we all know if you go out and you have a couple beverages on an empty stomach, you get drunk faster. Problem is you also get hypoglycemic too, because alcohol has the effect of blocking gluconeogenesis. So, you should be able to, even if you didn't eat, you should be able to mobilize those stores to your blood, but alcohol actually blocks that. So you can actually get hypoglycemic with alcohol ingestion. This is important. They always ask about this NADH to NAD ratio. So that is what actually blocks the gluconeogenesis. We'll go through the pathways when y'all do DM to show y'all what we're talking about. But it's just you need the NAD when you go through the Krebs cycle and all that nonsense. And if you don't have it, then ethanol just shunts everything away from gluconeogenesis. And you start going through anaerobic glycolysis. But that's a problem for another day. Insulinoma, secreting insulin. So would you expect your C-peptide to be elevated? Yeah, of course, right? Because you're making endogenous insulin. Right, severe hypoglycemia, just because of all of this insulin is getting all the glucose out of your blood. Here's what I was talking about. So if you were to inject insulin versus it being endogenous, if it's injected, it's not attached to a C-peptide, it's just pure insulin, so you won't get this. But sulfonylureas actually help you to increase the production of endogenous insulin. Okay, so you're not, these aren't insulin pills, these are just help to increase the levels of insulin made in your body. So you'll get a high C-peptide. I'd say this is fair game for the test, right? Especially these first two columns or rows. All right, calcium. Right, and we kind of talked about this. 99% calcium is in the bone. The whole point of PTH is to help regulate that. Vitamin D and PTH kind of go together. There's a few exceptions we want to talk about. Ionized form is the form you want because it's free. If it's free, you can use it. If it's bound up, that's a problem you see here. It's physiologically active form. All right, so what are we talking about? So there's 3 methods of increasing your calcium or regulating your calcium. First, you can increase the absorption through the gut. That's a big plug, a big component of what vitamin D does, right? So if you have adequate vitamin D levels, you're able to bring in calcium and phosphate. Remember, vitamin D will bring in both together. Now, you can also work on the kidney. Now, this is more where PTH comes in. Now, it's going to titrate your calcium. It's going to help you to retain calcium and kick out phosphate. Let me just do this because I want to be sure y'all get this. So vitamin D, and it's not that straightforward. Like PTH also works in the gut and vitamin D also helps in the kidney, but for now, like this is good. So vitamin D will increase, primarily in the gut, will increase your calcium, your blood calcium, or your calcium uptake. And it will also increase your phosphate too, uptake. Okay. Now in the kidney, we're mostly talking about PTH. And it's going to increase your blood calcium. So it's not going to let you pee it out. You're going to hold on to it. But it's going to also decrease your blood phosphate. So you're going to pee out all the extra phosphate. So what does this mean when you're reading through the notes? That's a big, oops. That's a big exception right here, right? Big difference. Now, like I said earlier, worst case scenario, you can pull it off the bone. That's not an ideal circumstance. But if PTH does pull it off the bone, those calcium phosphate, those are crystals, they're together. So you have to pull the calcium and phosphate together off the bone. But once PTH works on the kidney, phosphate's not really super important in the body. It just kind of hooks up the calcium. So you want to get rid of it if you can. All right. Yeah, and again, you're trying to get rid of that phosphate with PTH in the kidney. And of course, that extracellular calcium is what's going to help to regulate, both. If your calcium in your blood is low, it's going to upregulate PTH, but PTH is going to actively keep your blood calcium levels adequate, right? So you don't want to pull it off the bone, but by all means, you have to have enough in your body, right? Because we need calcium for muscle contraction and for your heart to beat and all that stuff. All right, so yeah, this is just how it works. If there's not enough ionized, remember ionized is the active form calcium in the blood, you can increase PTH. Again, PTH is going to increase your calcium and phosphate from the bone, but that's the last ditch resort. But it's also going to decrease calcium levels by excretion and increasing calcium resorption by the kidney. So so think about vitamin D pulling it in from the gut as it needs it as much as you can, and PTH just titrating it in the kidney. And then it's a last ditch effort if you have to go pull it off the bone. Of course, I've seen this a million times when we talk about vitamin D. UV light will help to convert it to cholecalciferol. 25 hydroxylases in the liver, and then in the kidney, which is probably the most important part, you convert it to, with 1 hydroxylase to 125 cholecalciferol, okay? Why is this important? Because people that are in kidney failure this doesn't work in the kidneys. So you're stuck with this form, and this is not active. So people that are in kidney failure or renal failure, they tend to have to take vitamin D supplements, right, as the active form. All right. Yeah, and so, right, remember vitamin D, like steroid hormones like thyroid hormone is going to go straight to the nucleus, and it's going to help to modulate gene expression. What is it going to do? It's going to upregulate calbindin, and calbindin is intracellular. But what it's going to do is it's going to, by upregulating this in the intracellularly, it's going to help to bring calcium from the gut into the bloodstream. Again, phosphate is going to have to go with it. Now, like it says here, calcitonin doesn't really, at least mostly in adults, it doesn't have a huge role. But if, just for completeness sake, it does actually, help to keep calcium in the bones. If you have some sort of bone pathology, it can use this as a drug treatment to actually use salmon, however you say it. Salmon, they figured that out. Salmon calcitonin, you give it to humans that, with some of these bone problems. Yeah, so it's, if you're dumping a lot of calcium in your blood and you need something to keep it in there, you can take some salmon calcitonin. Fun fact. All right. Hyperparathyroidism, what would you expect? Well, you're pulling a lot of calcium off the bone, right? That's a problem. You're going to get brittle bones, or it's going to be demineralized bone. Also, you don't want a lot of extra calcium in the blood. What's that going to cause? Kidney stones. That's a big problem. Yeah, stones, bones. They say psychiatric overtones because it does cause brain issues too, psychiatric symptoms and abdominal pain as well. So yeah, so that's the main thing you want to worry about is these kidney stones. Secondary, usually, so when you say it's secondary, it's not an actual problem with parathyroid hormone. It's a secondary cause, so you're thinking usually it's vitamin D, some sort of vitamin D deficiency. You're not getting enough sunlight or whatnot. So what happens there? So because you're deficient in vitamin D, you're not absorbing calcium, okay? Now, what that means is you're going to get an increased serum PTH, right? Because this PTH is recognizing that you don't have a lot of calcium. Okay, so that's what's going on there. And again, it's a secondary cause. So how do you treat this? You can give some sort of vitamin D supplements. Kidney disease is the example they usually use. Rickets, right? And they're the same thing. It's just, rickets is in kids, osteomalacia, it's in adults, vitamin D deficiency, bowing of the legs. Typically, it's always, this is your buzzword here, demineralization, okay? So you're not actually mineralizing the bone. It's like woven bone or immature bone. You're not actually making it dense. So that's why they get bowing of the legs and stuff like that. Now, hypoparathyroidism. So you're going to have low blood calcium. And why would you get high plasma phosphate? Well, because if you don't have PTH, you can't, specifically in the kidney, you can't regulate the phosphate levels, right? You can't pee out the phosphates if you get increased phosphate and low calcium. What does hypocalcemia cause? Tetany, right? Anytime you have hypocalcemia, you're messing with that equilibrium potential, and that will cause premature muscle contractions, muscle excitability. Of course, the heart can be affected as well. Yeah, right. So again, you should probably know these words. Javetsky sign. So again, you kind of tap on the cheek and it causes it to twitch. That's a sign of hypocalcemia. Trousseau sign. Similarly, if you pump up a blood pressure cuff, it makes the hand kind of contract. It goes into tetany. So hypocalcemia correlates to tetany or locked up muscles like that. All right. That wasn't terrible. I don't think. How long did we take? Oof. Okay, maybe it was. All right, we'll take a 5-minute break and then we'll go to reproduction. Yeah, I see. Yeah, I think the hardest thing about this exam was the repro histo stuff because it all looks the same. It still looks the same to me. So I'll do my best. And there's nothing I want to do more on a Sunday than mansplain the menstrual cycle to a bunch of females. So if I say something,
yeah, he always forgets he has a female partner.
Okay, well, yeah, you know. Yeah, so
Yeah,
don't
he
judge me.
always makes that joke, and I always tell him, you know.
There's an LH surge. We're good. I figured it out. All right, let's do this.
Oh my
Pelvis
God.
and perineum. The anatomy, y'all covered this in MSK. This isn't super important. We're going to hit the high points. Remember that perineal body is an anchor point for everything. They really don't do episiotomies as much anymore unless there's like a really big baby. But the idea is that sometimes they have to do an episiotomy on the side here. But the whole goal is you don't want the vagina to rip down to the perineal body because this anchor point, it doesn't heal very well. And it's an anchor point for so many muscles. But that's an important point to know. It's kind of where all the muscles come together. Yeah, all right. Yeah, so Colles fascia, yeah, is continuous with Scarpa's fascia, right? So it comes down and you can see, so y'all must have talked about like the Beck's fascia or Beck's, we'll get there. All right, and then you can see here, some of the important points. Remember the external anal sphincter is under somatic control where the internal anal sphincter is autonomic control. Same thing with the urethra, external is somatic, internal is autonomic. So those are important. But for clinical aspects here, this is just basic anatomy. Y'all covered this already, so it's not going to come up too much. Yeah, so, yeah, this is a conduit for infection as well in this area. These abscesses lead to fullness in this area, this ischial-anal fossa area. So I would be sure to do the Gray's questions, but again, this module is much more based on clinical medicine than anatomy. I know I don't like the anatomy of the pelvis. Doing it in 2 dimensions is like doesn't do it justice. You really need to appreciate it in 3 dimensions to like understand what's going on. So yeah, again, you can see the perineal body. You can see how this fascia kind of continues here, the perineal membrane. So yeah, Buck's fascia, right? That's when they talk about those injuries. We'll get there. Yeah, so this perineal membrane is what's going to actually separate the superficial and deep pouches right there. And yeah, again, same principle, find the perineal body, and then this perineal membrane is what's going to separate everything. And you can see this is Dartos fascia, which comes around the scrotum here. And Colles fascia is continuous with Scarpas from the abdomen. Yeah, this is a good point to know, though, if they can ask, well, what's actually in the deep pouch versus the superficial pouch. So you can read that here, what goes with what. All right, and then the pelvic diaphragm, or the floor muscles of the diaphragm. The major question they ask is when you are incontinent and you lose innervation of these pubococcygeus muscles. That's what they'll ask. Patient comes in with incontinence, and they ask you what muscles or group of muscles is to blame, and that's those pubococcygeus. They make that ring around the anus, so that helps you be able to control your defecation. All right, and my favorite pouch, the pouch of Douglas, the most underrated pouch. This is where all the fluid develops if the patient is upright, if you have some sort of trauma. If you remember, the patient is laying down supine, it can develop in Morrison's pouch, but here is the rectouterine pouch. Obviously, guys don't have a uterus, but they have the rectovesicular pouch. But the pouch of Douglas is very important because that's where, if there's a trauma, all the blood's going to collect. Okay, so you absolutely have to know it. They ask it, that we still get cumulative questions about it. I have a group chat called Douglas pouch because it's that important. Okay. Yeah, trauma, internal bleeding, you can find that. Yes, and then a coldocentesis. Again, if you're expecting fluid, it could be an infection too, not just trauma, but if there's some sort of fluid there, you go through the posterior fornix of the vagina and you can aspirate that fluid as well. Okay, so don't forget that. And then remember this, it's external venous plexus of Batson. I believe that's what it's called. External, internal venous plexus. Anybody?
Yes, internal.
Internal, thank you. Oh, sorry, there it is. Internal venous plexus of Batson, right? Remember, it is a valveless structure, okay? So there's no valves for this venous transport back up to the heart. So you can get a lot of metastasis. So if the prostate, if it's going to metastasize, it's going to go through this valveless system. So they definitely could ask that. That's an important point. All right, lymphatic drainage. Nobody likes lymphatics. Just remember it being superficial versus deep. It's important, but remember, like the testicles, because they descend down, they're going to go to the lumbar nodes. You can see that here. Testes drain to the lumbar nodes, of course, the ovaries as well, and then just kind of separate everything. The body of the uterus is all going to go to external, internal. They shouldn't put both on the exam, right? Because it kind of just splits and it goes together. So I wouldn't imagine they put both. And then everything, I believe it's the lower fourth of the vagina. So the superficial area is going to drain into the superficial section. Okay, and then you could read that here, internal iliacs. All right. Yes, so remember, this is easy to remember because sacral splanchnics is sympathetics, S and S, pelvic splanchnics, P for pelvic, and parasympathetics. Okay, now the pelvic pain line, people get this confused. All they're saying is what are the pain fibers, right? Visceral afferents, visceral meaning organ. So these visceral afferent fibers are going to either travel with the sympathetics or going to travel with the parasympathetics. So if you're above the pelvic pain line, the visceral afferents are going to travel with the sympathetics. Yes, sympathetics. Sorry. And if you are below it, it's going to travel with the parasympathetics. These visceral afferent fibers are very tiny. So like they're not going to travel on their own. They just hitchhike along with these other ones. So that's all the pelvic pain line is saying. You're asking yourself, what are these pain fibers, these visceral afferent fibers traveling with? Okay. What else? Good point here. They will try to make it difficult and be like, and they'll point to like the very lower aspect of the cervix and be like, where does the pain travel? Remember, this is the point, right? This is the point we're talking about. This is the pelvic pain line. So that lower aspect of the cervix is below it. Okay, so just keep that in mind. But everything above it, the ovaries, any ovarian pain, the fundus of the uterus and stuff like that, fallopian tube pain, that's all above it. Everything from the very lower aspect of the cervix and below is below it. All right. Right, and you could see this here. Somatic, right? So you would expect pain, somatic pain. So if we were talking about stuff like hemorrhoids, external hemorrhoids, those are very painful, okay? And that's because they travel with somatic fibers. But if you go above the, to the internal sphincters, above the pudendal line, you're going to travel with, they're not going to be somatic. They're going to travel with the autonomics. So those are painless. So they will ask you external hemorrhoids versus internal. They say which ones are painful, which ones are painless. You know, the pudendal line. I should have another slide coming up for it. But just remember, the further you go towards the outside of the body, the more likely it's going to be somatic, right? So the low, yeah, there it is, the lower 1/4 of the vagina, penis, clitoris, yeah. So everything that's very superficial is there. All right, and again, same thing. This is just one little exception. Anything that is erectile tissue, even though it seems very superficial, it is very superficial, it still travels with the deep inguinal nodes. Okay, but the skin is going to go superficial. Okay, so that's a good test point because it's a little tricky. All right, pudendal canal syndrome. It's just a compression of the pudendal nerve, right? If you're sitting down too long on it, you can have a compression. So it could actually lead to, most likely it's going to be just burning or numbness in that area, but it can get worse because that pudendal nerve supplies branches to the penis. You can get incontinence and sexual impotence as well. All right, yeah, just looking at the guy, right? So you can see this vas deferens actually goes, the sperm is made in the testes, and you can see, it's actually made back here in the seminal vesicles, and it's going down to, nope, sorry, wait, I'm wrong. Hold on, it's made in the testes, and it goes up here and it's stored in the seminal vesicles and the prostate, right? Of course. So you can see that here. You could appreciate the prostate here. Yeah, again, what is this? Not the pouch of Douglas, because it's a man, right? This is the rectum vesicular bladder pouch. All right, pouch of Douglas is in reference to female. Rectum vesicular. All right. Good point to be made. The left testicle, the drainage point, the testicular artery, goes directly up to the left renal vein. You see this drainage, whereas, and I'll ask you this too, where the right renal, testicular artery goes into the inferior vena cava. Okay, so that's another one of those weird differences that happens, but you could see this is what, it goes straight up here. Okay, so be aware of that. Yeah, and here we go. Ductus deferens, sperm here, goes all the way up, and it's stored back here in the seminal vesicle for ejaculation, and there's some in the prostate. You can see that here. Do I have, yeah, here it is. Okay, right. So this kind of sits behind, if you're looking at the posterior aspect of the bladder, and you can see the seminal vesicle here. You can see the prostate, the ejaculatory duct. But this is what I want to show you. So orient yourself here. What are we looking at? You can see the pelvis here. This is an AP view, anterior posterior, right? So you can see the seminal vesicles here. So you could appreciate everything here. So ductus deferens or vas deferens is coming up, bringing the semen or sperm to be stored here. This is the ampulla or the opening to the ductus deferens seminal vesicle where everything's stored, and the ejaculatory duct is right around the prostate down here. Okay, so I think this is fair game as well, showing you a picture like this and asking you what that is. Looks like they did some sort of retrograde dye. They probably injected it directly into the ejaculatory duct, and it went retrograde through, so you can see all these structures. All right, and we talked about this already. Obviously, you can imagine if this prostate gets large, like guys with, with AIDS, they get benign prostatic hypertrophy or hyperplasia, excuse me. And this gets swollen, it makes it difficult to urinate. All right, again, what's important about this, again, they use some sort of dye, this retrograde dye to fill up the bladder. You could see that this is a big constriction point. It makes not a 90-degree angle, but pretty close. So this membranous urethra being so, it's not small, but so fragile right here, is a good point, not a good point, but a common place for injury. Yeah, so you divide it there. So everything past this point, membranous and prostatic, will be into the posterior aspect, and bulbous and the penile portion is anterior. And you can appreciate that here as well. All right, super important when we talk about, let me see if I have another slide. Yeah, okay. Which one was more important? The lobes. It's probably good to know both, but they kind of correlate, right? So, yeah, so like the transitional zone is going to be right around where this median lobe is. But what actually happens is, I think let's use this slide, it's a little bit better. Benign prostatic hypertrophy is going to be right around the urethra, and that should make sense because with BPH, it's very hard to urinate. So if you're squeezing or having increased cellular activity around that area, around the urethra, it's going to squeeze down, it's going to make it difficult to urinate. But the thing is with prostatic cancer, sometimes it's incidental finding. You might not have urinary symptoms. So on the exam, if they tell you that the patient has urinary symptoms, definitely lead towards BPH, just because the BPH is going to be around this area here, whereas the cancer is more of like a posterior aspect. Now, what does that mean? That's why you do a digital rectal exam, because you can actually feel it if it is. It's supposed to be like they say boggy or kind of like squishy, for lack of a better word. But if it's nodular, that tends to mean there may be some sort of cancer there. Usually it's an incidental diagnosis. That's why guys need to be screened for it when they're older. All right. Again, they put some dye up in the bladder. You can see that. Yeah, right. Cool. Again, this internal venous plexus of Batson, It is valveless, so you can get a lot of prostatic cancer metastasis through that route. All right, more anatomy. Corpus cavernosum. That's the area that's going to be filled with blood for an erection. Yeah, that's really all important. And they did ask us one of these weird questions. Okay, so remember, in an anatomical position, the penis is erect. So the lower side of the penis is the ventral side. The top side of the penis is you know what I'm saying, is the dorsal side, right? So that's how they define it. So, but they did ask us this weird question. I remember I got it wrong. It was like, so do you remember, Lindsey? It was like something about the dorsal artery. Like what? I forget. But they did ask us about that. So if y'all come across a practice question.
Yeah, I do remember the dorsal artery of the penis being a question, or dorsal artery of the end nerve.
Yeah, it's been a while, but that did come up for some reason. So yeah, not that that helps you guys, but just maybe if you come across a question with it, keep it in mind. All right, so now when we have injuries, you want to define these injuries based on if you injure Buck's fascia or not. So if it's anterior, it won't rupture Buck's fascia. So all of the urine extravasation will be just in the penis area, okay, as you can see here. But if you actually injure Buck's fascia and it gets worse, you can see this butterfly effect. So Buck's fascia is ruptured here, so all of the urine can actually go all the way up here. So that's definitely going to be a test question, injury to Buck's fascia or not. Then they refer to this as this butterfly shape. So yeah, so look, this would be like, if you look at the anatomical position, this front side, even though it's the bottom side, technically, that's the anterior side. And the top side is the dorsal side, okay? And then posterior urethral tears, they usually talk of these as straddle injuries, okay? So they'll usually say it's a high riding prostate, okay? High riding prostate because it tore in this posterior area. So high riding prostate saddle injuries, and that typically is, well, that's a posterior urethral tear. So those are some buzzwords for you guys. All right, so we know the mnemonic point and shoot to get an erection. It's parasympathetic. To ejaculate, it's sympathetic. Yeah, we kind of talked about this process. You get engorgement of the cavernosum, and yeah, that's how. So blood pools there for an erection. Point, shoot, ejaculation, sympathetic. Right, maybe good to know inferior hypogastric plexus is involved as well. So that's how that works. Now, the females, ovaries, some of these ligaments are super important. The one that is connecting the ovary to the area of the upper area of the uterus is the proper ovarian ligament. The suspensory ligament kind of holds everything up like that. So you can see the fallopian tube here, but in the suspensory ligament, you can see those ovarian arteries and veins that travel in there. Okay, that's an important point to know. And yeah, so contained ovarian ligament suspensory. Now there's also, well, we'll get there in a second. Right, so obviously when the egg is, when the follicle ruptures, it goes up here, it's collected by the fallopian tube, and the ampulla is where fertilization usually occurs. This is also the most common place for ectopic pregnancies. Usually it's secondary, well, commonly it's secondary to pelvic inflammatory disease. So if you had some sort of, STD or some sort of infection there, it causes scarring of the fallopian tube. So the fertilized egg can't make it back to the uterus, okay? So if they talk about some sort of ectopic pregnancy, which they probably will, the area is the ampulla, okay? Yeah, okay. Right, which is the widest portion where everything happens. Right, so just, yeah, so it's the uterus, if you look here, this is the posterior side, that's the rectum. So it's anti-flex and anti-verted, everything's pushed forward, okay? And yes, of course, for HPV, you have to do pap smears. This is what you check. So yeah, HPV, this is a slow growing process, takes years to develop any sort of carcinoma in situ or cervical cancer. So that's why women need to be checked regularly. All right, and we look at this broad ligament. It's like a cape-like looking structure, right? Suspensory ligament here. Again, ovarian arteries come here through here. You can't see, but there's a cardinal ligament that comes through here also, and it actually has the uterine artery and vein as well. So that runs right about that way. So yeah, so the broad ligament makes up the mesometrium, mesovarium, and mesocell pancreas, right? That's this whole broad ligament structure. No. All right, oh, here, okay, so here's cardinal ligament, right? So it comes across. So when you do a hysterectomy meaning you take out the uterus, you have to ligate the uterine artery and vein. Again, they come through the cardinal ligament here. So one of the important points is this water under the bridge analogy. So if you're doing a hysterectomy, the vessels, the uterine artery and vein kind of sit on top of the ureter. Okay, so you need to cut the uterine artery and vein, but you don't want to cut the ureter, right? So that's why they say water under the bridge being the vessels, water being the urine and the ureter. So you just want to make sure you don't go too far, but that's a common test question. All right, if we get into pregnancy, which I'll do a lot next week, which I'll try to talk about a little bit later. If you're measuring fundal height here, that's kind of how you do it, top of the uterus to the pubic bone, okay? And then blood supply, again, these uterine artery and vein, they come through the cardinal ligament. Suspensory ligament is gonna have this ovarian artery and vein, and then of course the uterine tube here. And then you can technically divide it because it has dual blood supplies, some coming from the pelvic area, some coming from the abdomen. Yeah, and I kind of just illustrated that here where everything kind of comes from. All right, ectopic pregnancies. Again, when we talk about this, one of the problems leading up to it is pelvic inflammatory disease because you get scarring. So sometimes that egg can't make it all the way to the uterus, okay? And most common location is the ampulla because that's where the actual egg is fertilized. A risk factor is PID, pelvic inflammatory disease. Again, we talked about episiotomies. You don't want to have this vertical tear to the anus, right? Because you're going to tear through the perineal body. If you do that, it doesn't heal very well. So again, now they you know, at least if the baby's head isn't too big, like macrosomia, they do have techniques because, I mean, nobody wants to have this done. So, you know, they do have techniques to where they can avoid this. So this isn't a common problem. It's more of an emergency. All right. Yep, we talked about this. Above the pelvic plane line, the visceral afferent, those pain fibers travel with above the pelvic pain line, the visceral afferents travel with sympathetics. Below, they travel with parasympathetics. You will get a test question on that. All right, again, PID, it's an ascending problem, so it can even get into the abdominal cavity, but you can imagine that if there was scarring here, it's hard for this fertilized egg, which happens about right here, to make its way to the uterus for implantation. All right, let's orient ourselves. We're looking at an AP view, right? So you can see the pelvis side by side. They put this retrograde dye in. You can see the uterine cavity here. So what's this? This would be the fallopian tube right here that's coming off. You can see that ampulla, the tube, right, the uterus. So again, just like the seminal vesicle in a guy, I think this is fair game as well. Same thing, same principle here. You can see them putting in the retrograde dye. The uterus is lit up, and then you can see this fallopian tube coming across. It looks like this one's actually, maybe it's scarred over or something. It doesn't look like the dye is coming through on both sides. Yeah, there you go. And yeah, it's an awkward picture. So this is what happens, uterine prolapse. That's unfortunate, usually secondary to pregnancy, multiple pregnancies and stuff. It has to be surgically corrected. All right, male reproduction, right? This is where everything happens, and sperm development, seminiferous tubules, and then everything goes through epididymis to the vas deferens and goes up and it's stored in the seminal vesicles. All right, so most of it, well, yeah, so as it travels, the seminal vesicle will have about 60%. Some of it is going to the prostate gland. Why do you need alkalinized fluid or alkaline fluid? Because the vagina is acidic, so for the sperm to survive, it needs to have alkaline fluid to help offset the acid. And this is just the process of the sperm being made, right? You could see the Leydig cells again is going to help make testosterone, but when you talk about the Sertoli cells, you can see how everything is forming from the spermatid onward. Right, so high yield, we're going from the processed spermatid, and then you're going from, yeah, here's a better picture. So you're going from down to a haploid sperm, right? Or so it could be fertilized, it's 23X, so that, or sorry, it's 23 chromosomes, so that mom could fertilize it too, it'll be 46 total. So the sperm will be haploid, or 1N, right, 1N. And right, so, yeah, I think that's all. There is a good picture. It's a histology picture, but I guess it's coming up. Right. Remember that this came up cumulatively as well. Remember the Leydig cells isn't actually a part of this structure. It's kind of outside. So they do ask that. I think they pointed to this area here, and they asked us, you know, what hormone is produced there. So you had to know it was Leydig to know it was testosterone. But you can see here the little sperm as they grow, they go through, and I think, okay, hopefully it's coming up. And then this just goes to differentiation. Remember, the default pathway is to become feminine, to become a female, right? So you go paramesonephric, Mullerian duct. The aspect of having the Y chromosome is to have the SRY gene. The SRY gene will help to turn off these female characteristics. It'll secrete Mullerian inhibitory factor, which will help to decrease these female characteristics. Therefore, you can go towards the male pattern. Testosterone, 5-alpha reductase, and right, so Wolffian, guys are wolves, I guess. I don't know, however you want to remember that. Yeah, I don't know, but that's a good way. I don't know. So the mesonephric duct, right? And yeah, again, 5-alpha reductase helps to make that more potent form of DHT. Oh, and I did look it up. Lindsey was right, as always. T3 is more potent. I think I got it confused because T4 is more common, and they actually use T4 to treat hypothyroidism. But definitely take note that T3 is the one that's more active for sure. All right, now, one of the important components is GnRH is pulsatile in its secretion. Okay, so they do chemical castration sometimes. Y'all will learn that in psych when y'all get there. But if for whatever reason, if you give medication that causes a constant secretion of this, this can actually will cause a decrease in you know, your sex hormones, right? Because it has to be pulsatile. So even if there's a tumor or something that's causing a constant secretion of GnRH, you'll get like ovarian anovulatory cycles and stuff like that. Yeah. So they actually do, yeah, y'all will get into that in psych, but yeah, that's just, right. So if you can't have GnRH, or if it's a continuous secretion of GnRH, your LH and FSH will be off, and then you can't go down to testosterone and stuff. Right, so remember the Leydig cell is gonna help to upregulate testosterone. Of course, the Sertoli cell is going to help the sperm to grow. So you can see that there and mature. Right, okay. Beta HCG, I don't know why I put this in here. Yeah, well, of course, well, definitely important that testosterone does help with testicular descent. Meaning if you have low levels of testosterone, you can get what's called cryptorchidism, right? So one of the testicles or both don't descend all the way. And if they don't descend, you know, it could be found in the abdominal cavity, it could lead to cancer and stuff like that. So that's definitely important. And of course, you know the effects of testosterone, secondary male characteristics to produce sperm, sex drive, long bone fusion, increase your metabolism, even increase your hematocrit. But in regards to long bone fusion, remember, you know, after puberty, that's when you really get more testosterone. So until that point, you're kind of growing, and you know your testosterone levels don't get to adult age till about 18 or 20. So that's at the point where those epiphyseal plates will close. So testosterone will primarily be bound to sex hormone binding globulin. This could be problematic if you have some sort of liver failure, because then you can't make these binding hormones. And if you can't do that, you can't properly transport testosterone, among other things. Again, this 5-alpha reductase keeps coming up. It's very important to be able to convert testosterone to DHT. Again, this is the same thing we looked at earlier, male versus females, Wolffian versus Müllerian. Right, we talked about this. We could add inhibin to the process. Remember, inhibin comes from Sertoli cells, okay? And it's gonna feed back on the anterior pituitary. So don't get it confused as it's going all the way back up to the hypothalamus. They could ask you, where does inhibin work, or what directly inhibits FSH secretion? That's inhibin from the Sertoli cells, okay? Yes. Right, and we talked about this again, point, shoot, erection. Vasodilation is how you develop the erection. Nitric oxide is a vasodilator, so it can be used as well. That's how sildenafil or Viagra works. It uses cGMP to increase nitric oxide to cause vasodilation. And you can see that here. That's how Viagra works, right? cGMP is the nitric oxide pathway. Increased nitric oxide, increased nitric oxide will cause vasodilation, so you can get an erection. Now, hypogonadism, usually when you talk about this, you're talking about decrease in testosterone, right? So are these non-functional testes. So again, if you don't have that testosterone, you can't shunt away from the female development, right? That's the whole point of testosterone. So these kids will have ambiguous genitalia and stuff like that. And ironically, so why would they be taller? What did we just say about testosterone? Right, we said that once you get elevated testosterone, it helps with long bone fusion, right? So if you're not making testosterone, ironically, they'll be tall. You wouldn't think that, or at least I wouldn't think that decreased testosterone would increase in male height. So that's one of those things that stands out that may be good to know, right? So if you don't have testosterone, you're not going to close the plates. You won't fuse the long bone, so you'll keep growing. All right. And of course, if you lose loss of testes post-puberty, you're more worried about those secondary sexual characteristics. This is interesting because it has two effects, adiposogenital syndrome. So it is, if you're not secreting GnRH, you're gonna have those downstream lack of sex characteristics, but it's also really close to this feeding center. So you also get obesity as well. So adipose, think fat, fat formation, and genital, think, GnRH issues. I don't know if these numbers are important. Probably good to commit to memory. You want to have about 120 million sperm. Below 20 is considered infertile. Oh man, all right. Let's just keep going. How about that? Female reproduction. Okay. So we're talking about the theca cell and the granulosa cell. Remember, it's a process. The theca cell is going to take cholesterol and make androstenedione, or get to the point where you make testosterone. Then it's going to be kicked over to the granulosa cell, where that testosterone, or androstenedione in this case, can be used. Remember, aromatase, also called CYP19. It can be converted to estradiol, all right? And then you can use it as estrogen. There is a tricky thing, I think, Dr. Mandolini did this lecture, but there is something there. It's coming up. Okay. This is it actually. Okay. For whatever reason, late in the follicular phase, the granulosa cell also starts to have LH receptors. So you could think of it as at this point, at the point of ovulation, the granulosa cells can do everything technically, right? They could take up cholesterol, make androstenedione, and then they could actually make it all the way to estrogen. I don't know if he ever went into why. It was just a good point to know that at this point you actually express LH receptors. Are the theca cells completely inactive at this point? I don't think so, but it's just good to know that at this point, these granulosa cells actually also have LH receptors. I remember him making a point about knowing that. All right, now, so we have the follicular phase or the estrogen phase and then the luteal phase. So remember, estrogen and progesterone, they work together, but they don't typically work at the same time, okay? So when you want to develop the follicle, you want to use estrogen, okay? So your FSH at the very beginning of the menstrual cycle is a little bit elevated. You're kind of stimulating the follicle. You're telling it, okay, wake up, like, let's go through ovulation. And you're also going to get increase in estrogen here. So that's through that follicular phase. Now there is a point, I'm sure I have more pictures. There's a point where this estrogen dives down and this progesterone comes up. And that's the point at which you have this LH surge, which is the huge point, the most important point, because that tells the follicle of rupture. That's when you go through ovulation. Okay, so at this point, you're switching over from the follicular phase to the luteal phase. Now, remember, all through this follicular phase, the endometrium is being primed for being able to, for implantation, right? So once you get to this phase, the endometrium is developed at this point. So if there is going to be fertilization, it can happen at this point. So remember, progesterone is considered the pregnancy hormone. So as long as progesterone is elevated, implantation can happen. At this point, right about here, if the body doesn't sense that there's implantation, then progesterone will kind of die off, and then you'll go through menstruation, right? Now, what is the signal? The signal is beta HCG. Beta HCG, right? So, and it's going to come from the corpus luteum. So if there's implantation, the corpus luteum will secrete beta HCG. It'll actually tell progesterone, don't go anywhere. There's, the endometrium is implanted. So it'll keep progesterone up. The corpus luteum will keep secreting beta HCG until the placenta can be formed to do it on its own. So the point is that with progesterone, and it's a pregnancy hormone. So for viability, you always are going to have increased progesterone at this point, right? How does the body tell the first signal? It's beta HCG, and that's what a pregnancy test, a urinary pregnancy test, is looking for. So again, this will signal to progesterone to stay elevated, and so it can facilitate implantation and growth of the fetus. Again, the corpus luteum will continue to secrete beta HCG to continue to tell the body to keep elevated progesterone until the placenta can be formed, where it could take over making all the products. All right, good. This is a super important point too. So typical cycles are 28 days, right? The luteal phase is what's considered constant, so 14 days. The follicular phase, where if you have irregular cycles, is where the deviation happens. So this is a good testing point. This point from ovulation to menses is going to be 14 days. It's the follicular phase that if you're into that 28 to 35 range, that's where the variation happens. Okay, so again, we talked about estrogen. Estrogen is going to try to prime the body, prime the uterus for implantation, right before that LH surge. And it's going to also, let that follicle grow until it's large enough to rupture. And then at that point, progesterone will kind of take over. Similarly to testosterone, it is bound to this sex hormone binding globulin. And so it's bound to albumin, or bound in blood to albumin and sex. I guess it can also bind albumin, but I always think of it as binding to the sex hormone binding globulin. I'm not exactly sure why anyway, so sex hormone binding globulin, you need that there to help transport estrogens. Let's see. So again, you know the functions of estrogen at this point. Some of them are a little not as intuitive, but similarly to testosterone, it will help with fusion of the bones, okay? But yeah, secondary sexual characteristics as well. Prepare the endometrium for implantation. Right. Okay. Progestins, again, progesterone is going to be that pregnancy hormone. So it is going to help to develop the corpus luteum and develop the placenta. Again, these are very important components of pregnancy. Right, so it'll keep proliferating the uterine epithelium. Ovulation, meaning it's that point, remember there's that very important point where estrogen dives down and progesterone comes up, and there's our LH surge. So this is going to help with ovulation. Yeah, so glandular development of the breast as well, kind of works in concert, not exactly the same, but it works with estrogen. Just this is more of development in pregnancy versus estrogen is more of your post-puberty development. Right, and this is important too, right? You don't want any of this, because that could cause the baby to be delivered too soon. Right, so this is again what that slide was saying before. Remember, towards that late part of the cell cycle, the granulosa cells can actually exhibit, yeah, here it is, it's on this page. So let's just go through it. Theca cells will have LH early on in the follicular phase, and granulosa cells will have FSH, but after that LH surge, that luteal phase, the granulosa cells can now synthesize this estradiol on their own, right? So you get this LH here, and it could take cholesterol and go all the way to estradiol, okay? So just make note of that so you know that for the exam. And right, so positive feedback. Estrogen normally negative feedback. Oh, right, okay, so yeah, so estrogen will give a positive feedback system right at that point, and that will help to mediate the LH surge. So both progesterone, the upstroke of progesterone, and the action of estradiol here will help to have a positive feedback, and that will mediate that LH surge. And again, same thing as in guys, the whole point is to get to this haploid gamete, and you have 23 chromosomes, so that'll add 23, and that's how fertilization happens. This is probably the best picture. I think first aid, that's a better one. Yeah, they do, huh? Okay, we'll just use this. Right, so you look at everything together. This is the initial phase, follicle stimulation, develop the follicle, right? You get this little bump of estrogen, and then at this point, estrogen is kind of priming the endometrium for implantation. Here's our point, estrogen's diving down, progesterone's coming up. Around day 14, you get the LH surge, follicle ruptures. You do see this little elevation from the corpus luteum of estrogen, but that's not super important. The point is that progesterone is very much elevated here. If there is implantation, you will get beta HCG secretion, and that will keep progesterone up. I believe y'all go into the physiology of pregnancy a little bit more next week, excuse me. All right, and you can see it a little bit bigger here. Oh, this is from first aid, right? So same principle, just it's kind of good to be able to overlap everything and see how it all goes. All right, again, we talked about this, developing follicle stimulating hormone. That's what you want. Develop it, you're developing the endometrial lining there until the LH surge, right? This is the point where estrogen is going to switch to positive feedback. LH surge, that is going to be when the follicle ruptures and the egg's free to go into the fallopian tube, right? Hyperemia just means that there's increased blood flow, right? The vasodilation, so increased blood of the follicle. Then of course, corpus luteum will secrete estradiol, and progesterone will facilitate implantation. Right, and if no fertilization, corpus luteum is going to break down. There's no signal of beta HCG, so it'll break down. And then progesterone doesn't get that signal, so it's going to die off or tamper down, and then the menstrual cycle will start over again. Right. Yeah, we kind of talk about this. Remember, inhibin goes back directly to the anterior pituitary on FSH. Yeah, okay. So primarily when we talk about the corpus luteum, we want to think about it being able to hold the progesterone levels elevated. Okay, unless there's no implantation, and then everything kind of, go away. Puberty and menopause, we get that, right? GnRH will be elevated around that time. So you're going to get secondary sexual characteristics. Menopause, typically we talk about this decrease in estrogen, increased risk, of osteoporosis and things like that. Oh, here's a good point. Yeah, so what happens when you get decreased estrogen? Does your pituitary know? Like, no, right? It's just like, oh, wait, why is the estrogen low? So one of the signs that they used to see if you're going through menopause is you would have increased FSH and LH. So it's trying to signal down to the ovaries to make more estrogen, but there's no estrogen to be made because there's no more follicles. So for a while, your FSH and LH will be elevated. So that's a good testing point. We know this, hot flashes, all this. Yeah, osteoporosis, because estrogen has the effect of inhibiting osteoclasts, what eat the bone away. So if you don't have estrogen, those osteoclasts are overactivated, so they'll eat the bone. Birth control, so commonly, y'all will get into this a lot later, but if you give low levels of estrogen or estrogen progesterone combination throughout the month, you're going to prevent these surges, primarily prevent the LH surge because you're giving just low levels of it as you go. Yeah, exactly. Early embryology, great, everybody loves this, right? We would expect it to be the ampulla of the fallopian tube, where everything forms, where the egg is fertilized, that large opening. Remember, that's the common place of ectopic pregnancies. I'm not going to go through all this because we know when they talk about embryology, they typically talk about the clinical aspects. It is important though. I've seen questions where they ask what was the size of the 16 cell blastomere. That's always the merula. I don't know why that's important, but I've seen questions about that. Right, so what's important here, remember those syncytiotrophoblasts, right? That's where the implantation is, okay? So that is gonna be where that beta HCG is produced. Once there's implantation into the endometrium, those syncytiotrophoblasts are gonna be there. That's gonna be the first signal to the body that, that we need to, that there's pregnancy, right? So the syncytiotrophoblasts secrete beta HCG, the corpus luteum sees that, and it's able to secrete the progesterone, and it will keep everything viable. You won't get breakdown of the endometrium. So the syncytiotrophoblasts are very important in that regard. Cytotrophoblasts are going to be the cellular layer that we're looking at. All right, yeah, and this is the most important part, beta HCG, pregnancy test. That's what we want to know there. Ectopic pregnancies, again, the ampulla is likely where that's going to happen. If they ask a question, that's where it's going to be. And this is where you would expect the fertilization to happen. And the fetus, right? It lives in this little amniotic fluid, it breathes it in so that the lungs can mature. It also acts as a shock absorber, helps with lung development here, yeah. And this is just from first aid. Remember polyhydramnios, remember the child has to ingest the amniotic fluid. So if there's some sort of like tracheoesophageal fistula, something like that, where the baby can't breathe it in, you could lead to things such as polyhydramnios, oligohydramnios. If there's something like a renal problem, the baby's going to ingest a lot of the fluid, but you can't pee it out. So you can get oligohydramnios. So it seems like there's less fluid in the amniotic cavity. So yeah, then that's Potter sequence is related to renal failure or lack of kidneys, to be honest. So that would be meaning that the child ingested a lot of the amniotic fluid, but there's no way of getting it out. Okay, so definitely know the differences there. And this just goes into complications, probably what's important, right? So if you don't have enough amniotic fluid, remember it's so important for the lungs to develop. You need to constantly be, the fetus has to constantly be ingesting it. So if you don't have enough, you'll get lung hyperplasia. It could lead to respiratory distress syndrome. And if there's some sort of mechanical compression, you can get limb deformities. And then polyhydramnios, obviously, you know, it's that much extra fluid. It could lead to preterm labor or premature rupture as well. This is a traumatic thing, a traumatic issue that could happen if something, if there's a band patterning there. So there's no genetic component to it. It's just hapstance, like it just happens, and it'll cause constriction of this and can cause amputation or decreased blood flow to the distal limb or whatnot. Again, cystiotrophoblasts, beta HCG, keep the progesterone going, right? That's going to be our signal to tell the corpus luteum to continue to produce progesterone. All right, yeah, and the extra colomic cavity, first site of blood formation. I don't know why I put a thing around that, but I suppose know it. Allantois, right? So that's going to be that connection to the umbilical artery. So of course the fetus isn't breathing on its own. It gets all the oxygenation from mom. So everything can go through here and all the waste products, so mom can take care of it. Yeah, eventually it obliterates, right, to form the urachus, or the median umbilical ligament. Chorionic villi, again, we're looking at this this zone here when we look at the placenta, how it's implanted in here. So we just want oxygenation. We want these spiral arteries to come up, or these, these chorionic villi, not exactly spiral arteries, but come up. So everything can diffuse from mom here and the baby can pick it up. Hyetiform mole. Okay, what's important about this is, yeah, okay, good. What happens is a woman takes a pregnancy test and the beta HCG levels are elevated. So thinks she's pregnant, goes to see the doctor, and over time, not that long, the beta HCG levels will be through the roof, like 4 or 5 times what they should be. That is indicative that there's a hyetiform mole, okay? So if they tell you this, that there's really high beta HCG levels, that's what you're gonna want to be worried about, a hyetiform mole, okay? So just trophoblastic proliferation for whatever reason, but there's no embryo there. It's just the proliferation of the chorionic villi that forms. But like I said, this beta HCG is going to be diagnostic for that. Placenta, right? Good to know. The mom's side is called the decidua basalis, and the fetal component is going to be your chorionic villi, right? Attachment, yeah, sort of cytotrophoblastic cell, those inner cell walls. And again, since this is your trophoblast, beta HCG. Okay, we know this. Everything goes through from mom to the baby and back from the baby to mom. And you can kind of see it here. So this is the decidua basalis, right? So everything from mom goes here, and these little arteries can pick them up, and it can be distributed to the baby, into the fetal circulation, and then back out. Same thing from first date here, waste products back to mom, everything, including immunoglobulins, IgGs, pass to the baby. So passive immunity, that's how that happens. Right, erythroblastosis fetalis. Okay, so let me see, I did set this up. Let's see if this works, because I know people could get confused with this. Let's see if my internet's okay. So let's say mom is Rh negative, right? And she has her first baby who's Rh positive. This is just it's not important what the Rh does, it's just a component of the red blood cell, right? So if you're like ABO, when you think of blood types, not only are you A positive, but you also have a Rh factor. You're either Rh positive or Rh negative. All right, so this is mom. This is dad, oh, not dad. I'm getting tired, sorry. This is baby one. Okay, so what happens is when the blood mixes, mom recognizes that the baby is Rh positive. So she's actually going to end up making Rh antibodies. Now, y'all will do immunology a lot later, but these antibodies are recognizing some sort of foreign substance, right? So like if you have some sort of infection, you develop antibodies to it. COVID vaccine, we develop antibodies. So it's supposed to fight off infections, right? So it's recognizing this Rh as a problem, okay? Okay, so the baby's born, everything's fine. Now mom goes and she's still Rh negative, but now she has plus these Rh antibodies. Now she has baby 2. Now baby 2 happens to be also Rh positive. So now what actually happens is the fact that when baby 2, when mom's antibodies recognizes this Rh factor on the red blood cells, it's going to attack it, right? So it's going to cause lysis of the red blood cells. So that's a problem. That's what happens in these erythroblastosis fetalis, okay? So it's a very easy fix as long as you get prenatal care. They give what's called Rogan, and it helps to block this formation of antibodies. Okay, so that's the process. So it happens on baby number 2. After baby number 1, if mom's Rh negative and she forms antibodies, baby number 2, you need to watch out for that. Okay. Definitely know these depending on where they are. Previa, I feel like it kind of sounds like preview. So like it kind of blocks you from seeing the baby if you were to do a vaginal exam and you were trying to look into the uterine cavity. Not that you can, the cervix is closed, but I feel like it's like blocking preview, like previa. Placenta accreta is into the wall, accreta is into the wall, all the way into the myometrium, okay? If it goes even deeper, it can be in creta, okay? So deeper into the myometrium. Percreta actually goes all the way through to the perimetrium. So you can imagine this is where, so per and per, keep those together. So they can show you a picture, they can ask you about this. Regardless, this is a problem. It's very hard to deliver a baby if the placenta is in a way. If these are too far into the myometrium, you can get postpartum hemorrhage, right? Okay, dizygotic twins. It's just important to know that if they're dizygotic, they're fraternal twins, they come from 2 zygotes, okay? So that means they have to have 2 amnions and 2 chorions. Okay, dichorionic, diamniotic, those are fraternal twins. Now, if they are joined early in the process before the chorion and amnion, but before the placentas develop, they could be monozygotic. So you can have 2 amniotic sacs and 1 chorion, okay? So you can see that here, this 1 placenta developed this chorionic villi, but it actually formed 2 cavities, okay? You can actually, they didn't talk about it, right? So sorry, let me go back. Importantly, this came from 2 zygotes. That's how you differentiate them. That's why they form 2 separate structures. And monozygotic came from a single zygote. Okay, so you're thinking dichorion or monoamnionic, and dichorionic and monoamnionic. Okay, so you can also have mono, but they didn't talk about it in lecture, but you're thinking about identical twins in this situation, right? Single zygote, they have to have 100% the same DNA. All right, twin transfusion syndrome. Basically, you have twins in there, and for whatever reason, one of the babies gets more blood than the other. It's kind of, so you see 1 large baby and 1 smaller baby. So yeah, recipient versus donor twin. So you can see that here. Okay, so typically you can use amniocentesis for diagnostic purposes. You're about 15 weeks is where you don't want to do it before that. You can see here it says that there's not enough amniotic fluid. But if there's risk for genetic disorders like a trisomy, sometimes you can do ultrasounds and see like what's it called, nucleotranslucency, right? And sometimes that's indicative of there may be an underlying genetic disorder. If that's the case, you may want to get an amniocentesis. And let's see, alpha fetoprotein is very important because if it is elevated, it can be indicative that there's a neural tube defects, right? So if that neural tube is open, if for whatever reason the mom had low folate levels, that could lead to neural tube defects, so spina bifida, but that would cause an increase in alpha fetoprotein. What's important is that in contrast, a low alpha fetoprotein will be indicative of Down syndrome, or actually any of these trisomies. But classically, they talk about it in regards to Down syndrome. So increase alpha fetoprotein, neural tube defects, decrease, it could lead to one of these trisomies. You can see that here, definitely know that. Now, chorionic villi sampling is a little bit more invasive. You're not just tapping the amniotic fluid, you're actually going into the placenta, into the chorionic villi. But if there's a real concern, you can do that. You can do it about 10 to 12 weeks, opposed to waiting to week 15 if need be. And again, we talked about this, erythroblastosis, blastosis fetalis. Right, so you just want to watch out for those RH factors. And you can also do this umbilical cord sampling as well. Again, you're just trying to check the blood to see if there's anything that's indicative, any markers that are indicative of pathology or irregularities. Let me see something. How much more do we have? We could take a break in a second. All right, we'll take a break after this slide. Now just bear with me, please. Now, fetal monitoring, of course, right? We want to use primarily use ultrasound, and right, and you could also use check the fetal heartbeat as well. That's usually a good indication of health. So, right, yeah, cool. Okay, 5 minutes, and then we'll finish up. You ready? So a lot of this we've kind of talked about already. Obviously, beta-HCG, urinary pregnancy test, that's what we're thinking about since it's your trophoblast when the egg is fertilized and it's implanted into the endometrium, right? Right, and remember, this is going to signal to the corpus luteum to not go away because the corpus luteum has to secrete the progesterone to keep the uterus viable, okay? Keep the implantation, keep the pregnancy viable. You can see this here. ACG also has a male component to it. It can stimulate testosterone and descent of the testes along with testosterone. But more importantly, it supports the corpus luteum until the placenta can develop. All right, you can see that here up to about 6 weeks. Then you get placental development. And then from that point, progesterone can be made by the placenta. The pregnancy here, right? You can see the first trimester, you get elevated levels of beta-HCG, and then these hormone levels are going to kind of go up with the weeks of gestation, right? Until actually, well, yeah. So I guess we'll get to it in a second. But there's a steep decline at birth where progesterone dives off and estrogen comes up. So that's an important point. Now we know the placenta is going to provide support to the baby, waste elimination, hormone production, including the beta-HCG. It's going to produce antibodies as well and help with oxygenation. And right, all the same stuff. Yeah, and another good point, let's just point this out. There's no lactation while you're pregnant, right? That would defeat the purpose. So again, at birth, progesterone dives off, and then lactation is available once the baby's born. Estrogens, again, right? Remember that first phase, that follicular phase, prepares the endometrium, the lining, the body for implantation. It will also inhibit milk production. At that time, again, there's no point until after the baby's born, and it'll help with secondary sexual characteristics. Yeah, aromatase will help to convert it, androgens to estrogens. Again, so you want to convert those androgens to estrogens so there's no masculinization. Human placental lactogen, Why is this important? I don't think it's important. I guess it gives glucose to the fetus. Yeah, that's probably all you really need to know. Now, what's important, pretty sure all of the hormones that we've talked about go up in pregnancy except FSH and LH, okay? This is gonna promote follicle development and stuff like that, and we don't need that during pregnancy. But everything else is gonna go up to help stimulate the fetal development. So you can see that here, yeah. And if you just wanted to read through these, again, this is a bit much, but these are kind of all of the physiological changes, but they all kind of make sense, right? Like everything is to support the fetus and support development. Again, this is the only time calcitonin is really involved in fetal development, because remember, calcitonin is going to get the calcium out of the blood and put it on the bone. So when the fetus is developing, that's going to be super important. So I guess that would mean, oh, well, so but the parathyroid gland isn't really active at all. Okay, so no PTH. So I know I said these are the only things that go down, but PTH isn't even active at all. Okay. Right, remember they're flipped, right? Because the oxygenation, right, goes through the vein and then the artery brings it back just because you're coming from mom. So keep that in mind. It's one of the only situations besides the pulmonary vasculature where everything's flipped like that. So yeah. And we've talked about this. The fetus there's a left shift because it has to be able to pull the oxygen from mom, right? So it has a higher affinity for holding on to oxygen. It has a lower affinity for 2,3-BPG. So BPG promotes offloading, so the fetus doesn't use that as much, so it helps to hold on to it. So just know that there's a left shift so that the blood the fetus can take the oxygen from mom from the blood and get it to its own circulation. Now, preeclampsia, super important. Primarily, we talk about these two. I mean, you do get edema of the face and hand, but you have to have both of these to be considered preeclampsia. Most people would think hypertension, of course, right? But you also get proteinuria, which means there's so much hypertension, so much underlying issues going on that you're losing a lot of protein. So there's renal issues going on there too. So this is preeclampsia. If you address it, the goal is to address it so that it doesn't develop all the way into eclampsia, because this is not only an issue for the child, but an issue for the mother as well. And you can see the decreased renal blood flow, uterine blood flow. So you definitely need to address this, but most importantly, just remember these two components are going to be necessary for that to be diagnostic. Gestational diabetes, you don't have to have diabetes prior to being pregnant. Sometimes this just happens. Sometimes it goes away after, but this just means that you have increased blood glucose. The thing to remember is that if there's a lot of extra glucose floating around, there's a lot of extra glucose for the baby to eat, so you get a big baby, macrosomia. All right. I don't know why I put this in there. Corticotropin releasing hormone. I guess that it helps to develop for growth hormone. I guess that would make sense, yeah. The decrease in pregnancy at birth. Okay. Yeah, okay. I don't think that's important. Oh, here to tell us. Increase estrogen and progesterone. Okay, so that's why. Once this elevates, you'll get an increased progesterone and estrogen prior to delivery. I don't think that's very important, but. Right, so when we think about contractility at birth, we're thinking mainly oxytocin, right? We want to squeeze down on the myometrium, you see that here. And it's not just to deliver the baby and the placenta, but you also want to decrease postpartum hemorrhaging too. And then there's estrogens involved in this process, will help to tell the oxytocin. Remember I said at birth, you have this steep decline in progesterone and this incline in estrogen. So this is at, when at birth. Once this estrogen is rising, it can cause increase in oxytocin to stimulate delivery. Right. Also, what stimulates oxytocin is that stretch of the uterine smooth muscle. Right. So when the baby's large enough, it's like it's time to be delivered. You get this stretch, and that will lead to contraction. And then the cervix obviously has to dilate and to allow the baby to be delivered as well. So anytime the stretch of the cervix or dilation of the cervix, you get oxytocin. Remember, oxytocin is a feed-forward mechanism as well. So it's going to produce more oxytocin for delivery. Right, so estrogen progesterone ratio, that's what I just drew out. You get a drop in estrogen, so the amount of estrogen compared to progesterone is going to increase. You're going to increase prostaglandins. Remember, those will help to close the duct, the foraminal valley, right? So that the baby can breathe on its own, and it will help with delivery and dilation of the cervix as well. And you can see this again. We talked about this. Right. Again, estrogen. When you talk about secondary sexual characteristics, it's going to help to develop breast development, but progesterone will help with the end point, the third trimester development, and get the breast prepared for lactation after. We talked about this. Dopamine will decrease prolactin. Prolactin releasing factor. Remember, we use TRH for this as well. So don't get that confused. That will help with prolactin secretion. So it's just kind of the same situation. But the process is that suckling, the actual act of the baby suckling, will help to increase prolactin secretion. All right. So we have positive levels increase, inhibit milk production, right? We mentioned that earlier. There's really no point, right? The baby has to be born first. So this will help to inhibit lactation, even though the breasts are developing at that time. And we talked about this. Remember, when you're lactating, when you're making, making milk for the baby, there's no point in having GnRH to have cycles. So the first few months after pregnancy, you won't have a menstrual cycle. You won't have ovulation because this is inhibited. Oh, here we go. Transient after a few months, it's restored. Okay. Right, even the baby crying or things like that is a signal to the mother that maybe it's time for the baby to feed. Oxytocin will help with contraction to allow the milk let down. So remember, prolactin will help with milk production. Oxytocin is going to squeeze the musculature, squeeze down on the ducts, and allow milk let down. Okay, remember that initial, that first 2 days is colostrum. It's got a ton of antibodies in it, so it's super important that over the first 2 days, the baby get that colostrum. It's going to help for the baby's development. And a lot of other components. I don't think it's super important. The main thing is that you get a lot of passive immunity through the mom through that colostrum. All right, everybody's favorite. Oh, is this Lindsey stuff? Am I done, Lindsey? Yes.
You always pawn the histo off on me.
It's fine. You'll be all right.
I'm gonna keep my video off because my internet connection likes to go in and out, and a couple times it's been like, you've been unstable. So I'm gonna keep my video off so y'all can hear me. Am I controlling it?
Yeah, you should be good.
Okay. Is this my first slide? No, it's not my first slide. Come on. Brady, is this my first slide? I don't think it is.
No, but try to request access again to do it. Yeah.
I don't know why it is.
I'm trying to, hold on, let's see. Okay. Try again.
Okay. There we go. Okay. So we are going to follow the path of the spermatozoa. I took these straight from my slides, and so there are a bunch of markings on them because I didn't feel like erasing everything. Lazy, I know, but I didn't have access to your slides. So, okay. So we're starting in the seminiferous tubules. There, you have the convoluted straight and then the rete testes. Yes, you need to know the difference between these if they are showing it at a higher magnification. So straight tubules are lined by the Sertoli cells, and they have simple cuboidal cells. You can see this single layer right here. Sorry, I don't have a pointer or anything. Do you guys, I have an arrow on mine. Do you see this arrow moving?
I see the thing moving at, I don't know if it's you or Brady though.
Okay. Yeah. I think you tried. Damn it. I'm trying to go backwards. No, 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 no. Brady, can you go back to my initial slide? I'm sorry, this is not working.
Yeah, hold on, sorry. Yeah.
Thanks. Okay. Yeah, so you see the simple cuboidal cells, and then as you move down, you see the rete testes. So please know the difference in these. Goes convoluted to straight to the rete testes. And so this is your pathway of the sperm. We're going to go over the seminiferous tubule to, oh my God, I cannot talk. This structure in more detail later, because you do need to understand the different stages, because they will ask a couple questions, but right now just understand the difference, the pathway from the seminiferous tubule out. You have the convoluted, the straight, and then the rete testes. So again, we're going to go over the actual, the structure in a bit. The efferent ducts, you see this kind of sawtooth likeness to it. And so if you see this, this is, you know where you are. Again, really just know that this is the efferent ducts. I don't think there is too much more to it than that. So just understand that. Then the epididymis, you see you no longer have the more sawtooth like structure. I took this from, I made a review for myself. I'll post this because I have notes on that review so that you can go through the repro histo. It points out a lot of high yield points for you guys. But the biggest thing is, do you just know how to differentiate it? And then do you know the major function of the area? The vas deferens here. So the biggest thing that is important for the vas deferens, they like to use the example of the vasectomy. And the reason is because it has a very superficial course. And so you can access it pretty well. So superficial course, you have the vasectomy, sperm is just prevented from traveling further than the proximal ductus deferens. So that's what it is. It's just a barrier, which is also why that sometimes vasectomies don't work, because it is just providing a barrier for the sperm to move from location. So complications, you can have epididymis that is still producing sperm, and then you can get distension, and then you can get granulomas. Seminal vesicles, so know how to differentiate on the imaging studies. Why did I just have one with no pictures on here? I don't know why I don't have pictures on here. We're going to move on. Sorry, guys. This is a very high yield slide. I would start the male urethra. You do need to understand the different regions, and you need to understand the histology of the different regions, not necessarily by histological slide, but in the description of them. So for the prostatic urethra, this is aligned with transitional epithelium. The membranous, this is stratified or pseudostratified, and then the penile, which is spongy, which is pseudostratified columnar epithelium. You do need to understand the locations of these. So the prostatic urethra is, of course, the part of the urethra that is going through the prostate, and then the membranous urethra, this can be damaged. And so if you are doing like a Foley cath, you'll see that there is a very sharp bend right here with the membranous urethra, and you can get damage to this area if you aren't careful. And so that is the clinical correlate here. They like to use this bend. The membranous urethra is often damaged if you aren't cognizant of that. And then the spongy urethra, you have, notice where the ducts are. Again, not necessarily when looking at a histo slide, but just knowing the relationship between the two. So you have the bulbourethral glands, Cooper's glands. Please know both of those. Sometimes they'll use them interchangeably, but know where those are too. And then, yes, you need to know, you need to be able to look at the histo of the penis, and you need to be able to understand the corpus cavernosum versus the corpus spongiosum. The dorsal vessels, the deep dorsal vessels, I do remember that being a thing. I remember, like, you know, like Brady and I said, I don't remember exactly what they were talking about, but it was high yield. It was, you did need to know it. We're not going to talk about this on this slide because I believe Brady already talked about this, but I do want to reiterate the point. Please understand the clinical correlate with the Colles fascia and the Buck's fascia. You know, we talked about the rupture of each going into either the superficial pouch or the deep pouch and what that means. I just want to reiterate that there because that is very high yield and you are expected to differentiate between the two of those. Okay, the testes, so they descend retroperitoneal through the inguinal canal, obliterates and condenses to form the tunica vaginalis. That is important. Please highlight that. So you do need to know the layers because as they descend, they pick up layers and then those layers become different things. And so you have the tunica vaginalis, albuginea, and then you'll have the lobules with the seminiferous tubules. Okay, yeah. Know which is the tunica vaginalis. So the vaginalis is like which is superficial, which is more deep. That's the point I believe I was trying to make here with this slide. But yeah, vaginalis is the outermost. I would remember that the vaginalis right here is the outermost. And then deep to that is the tunica albuginea. Okay, this is when it gets important that you understand the seminiferous tubules. Yes, you need to understand, they love putting these as cumulative questions. And so they'll put this on here and you have to know the difference where the Leydig cells are, what's secreting testosterone, all the different hormones. And so start this, it's a really simple concept if you get it down and you'll get some cumulative points in the future. So they love to just point to a cell. They'll probably point to a Leydig cell, or they'll probably point to one of the cells on the inside and say what is secreted here. If this is, or yeah, I think, yeah. And then this one on the bottom left, where you have the different labels, make sure that you can label this as well. I can't do it off the top of my head. Does somebody want to go through these with us? F, A, B, C, D, E. They do like to do that. Anybody?
I can do it. I don't mind.
Yeah, go for it.
So I guess starting from the left, F, I believe, was the myoid cells, and then A was spermatogoin, and those were the oval nuclei. B was the Sertoli cells because they're elongated and pale, and I think I saw somewhere that said it like fried egg appearance. And then C was the spermatid, and then D was spermatozoa, and E was primary spermatocytes. And then I think the question mark, they said something about myelocytes.
Cool. Thank you so much for that.
Yeah,
Yeah,
no problem.
please know the difference between the cells and the importance of them. They will probably point to one, and something in the vignette is going to tell you about something. I don't remember the specific question, but I do know that was very high yield. It's very important. And then this one on the top right, I think they like to use for cumulative with respect to hormone production. Accessory glands. Seminal vesicles produces 60% of the volume, and you have fructose for ATP. This is important. So knowing that this is the function, like I said, some of this is really just knowing, okay, do you know what happens here? Do you know the significance of this area? So that's the big thing for the accessory glands. Prostate, I put the cartoon on here because this burned me when we went through ER. I only focused on the histo and I didn't focus on the cartoons. And they put something like this on our exam, and it was by the grace of God that I got the question right. So I just want to emphasize, make sure that you understand it both when it's represented like this, and if you know the histo, because the histo is, you know, a little easier to orient yourself, because I just focused on that, I guess. Prostate, citric acid for ATP, PSA, that's a big one. That's why if you are concerned about prostate cancer, that you can look for PSA, levels of PSA, and that can be indicative of well, you would just do a biopsy if you were concerned with the PSA. But all of these you need to know. But again, PSA is huge, and citric acid for ATP. But again, back to my comment about the cartoon, it's the transitional zone versus peripheral zone. And so the zones are what they like to talk about clinically when you are doing your DRE, your digital rectal exam, because depending on the consistency and the area, it can be indicative of either BPH or cancer. So understand that. Okay. Bulbourethral glands. The reason you know you are in this area are the concretions, and you are going to get the preseminal fluid from here. So really, you see those concretions, you know where you are, and then you understand the function is the preseminal fluid. So the one on the right, of course, this is going to be your prostate. And so your peripheral zone, if you feel hardness and it's in the peripheral zone, it's going to be cancer. Whereas BPH, transitional zone, that's where you're going to see that. Okay, female histo. This is a lot more complicated, I think, than the male histo, because if you just put the male histo side by side and you just spend a few minutes on it, you can kind of recognize the difference between all of them. Female histo is a little more complicated because now we're getting into the stages of the egg and differentiating between the two. And so pay attention to that. Because they love to correlate it with the hormones. So we'll go through how to differentiate. So primordial follicle, it contains the primary oocyte arrested in prophase 1. Very, very, very important that you know this is arrested in prophase 1. Primary oocyte arrested in prophase 1. Very important. They are numerous and just below the tunica albuginea. Remember, that is towards the surface of the organ, surrounded by a single layer of squamous follicular cells. So you'll see here the single layer. This is your big thing here, because as you progress to the later stages, you're going to have a lot more going on here. So this is going to be very easy to, or it should be easy to identify, or easier to identify, because of the single layer of the squamous follicular cells right here. And you notice that they are all bunched up here. Remember, this is just numerous, just below the albuginea. But the big, so that's just identification. But the big point here is primary oocyte arrested in prophase 1. And then you have a primary follicle, so you're containing the oocyte. So you'll see here that the follicular cells are now cuboidal, which makes sense, because if you're surrounded by the squamous ones, it hasn't really progressed, right? You're not producing anything, you're not maturing, and so it's just the flat cells. But now you're progressing a little more, and so the cells are beefing up because they have more activity. So those follicular cells are no longer squamous, they're cuboidal. And now you're starting to secrete the zona pellucida. So that also, so you see a small layer right here. It's not very large right here, but you start getting that production right here, and you can kind of see it, but that's not really how you're going to be able to identify. You're identifying it because of the single layer of cuboidal cells. So again, remember, it still contains that primary oocyte. I'm going to make this point: follicle versus oocyte. Just remember the two of those, because that terminology can trip you up. So we're looking at the entire follicle, but inside the follicle, you have the oocyte. Late primary, you see more of these follicular cells. So again, still the primary oocyte. It's the follicle that's changing. It is not the oocyte. The oocyte is still arrested in the same phase. Nothing's going on with the oocyte right now. So squamous cuboidal follicular layer, you're getting the stratum granulosum, and you have receptors for FSH that are containing aromatase. Remember, does someone want to say why aromatase is really important?
Make estrogen?
Yep. It will convert into estrogen here. Okay. So again, still primary oocyte, you're getting more of these follicular cells, you're getting more zona pellucida, but remember, but still it's not a whole lot. So it's really, you're just getting this stratified layer of these cuboidal cells. Secondary follicle, you're still containing the primary oocyte, you're just getting it ready, but now you see the antral spaces. This is what's going to differentiate from what we saw in the previous slide. So late primary versus secondary follicle, you get this antral space. So the antral space is telling you you're in the secondary follicle, still containing the primary oocyte, haven't changed with the oocyte. It's just the follicle is getting more and more and more robust. So this contains hyaluron and oocyte maturation inhibition. Then granulosa cells begin to organize into layers. So you have the thecal layer, you have the basal lamina. But really the big thing here is knowing that this is a secondary follicle, which is just the presence of the antral spaces. Now you get the Graafian follicle. So you have a rapid increase in size. We still have a primary oocyte. Proliferation is stimulated by estrogen. Remember, we had that aromatase that was there. So we now have estrogen here. So we just keep prepping and keep prepping and keep prepping. So along each stage, the follicle is giving us more and more and more to get to that terminal state where we can move on from prophase 1 and we can get ovulation. So we got that estrogen because we have the aromatase now. We're getting, which means that we get that rapid increase in follicle size. The cumulus oophorus, just hillock connecting the oocyte to the follicular cell, corona radiata. basically you just know what the Graafian follicle is, more identification than anything else. But that you can also see the large antral space now, whereas the secondary, it's smaller and there are multiple of them. But in the Graafian, there is a significant portion of the follicle that is made up of the antral space. And then you have the corona radiata or cumulus oophrys here. I don't remember this structure right here, the cumulus oophrys, being super high yield. I remember spending a lot of time on it, but it was more just identification, to be quite honest with you. And then ovulation. So the primary oocyte now undergoes meiosis 1 to become a secondary oocyte and is released from the Graafian follicle. And then the secondary follicle arrested. So that this probably shouldn't say follicle, this should say oocyte. I apologize for that. Is now arrested in metaphase 2, and it stays arrested in metaphase 2 until what point?
Fertilization.
Yep. So this is so Graafian and then ovulation. It's important to know the difference in meiosis when you get here. And then what's left over, the atreidic follicle. Several primordial follicles are going to develop in each cycle. The ones that don't release an oocyte become atreidic. It's just know that they exist, know that they're here. Then the corpus luteum secretes hormones that inhibit FSH and LH. So the granulosa part is estrogen, progesterone, and inhibin. The theca lutein part is progesterone and androgens. Yes, that is important. You need to know the difference between those two. Just knowing that there is a difference is really all you need to know. But we're inhibiting FSH and LH at this point. Now the uterine tube. 2 cell types, ciliated, columnar, under control of estrogen. Why is it ciliated? Well, we're carrying the oocyte down via peristalsis. So you want that cilia because it kind of beats the egg down the fallopian tube. And then you have PEG cells under control of progesterone. So this is secreting nutritive material for the ovum. Remember, progesterone is the hormone of pregnancy. And so if we are wanting to prep the egg for fertilization, then we need all this nutritive material. Know the difference between the two. I don't remember this being too high yield, but it is a difference. And I would spend a minute or so on it, understanding that. And then as you're getting closer, PEG cells increase and ciliated decrease. That makes sense because the ciliated cells are really important at the beginning of their journey because they want to get to the end. And as it gets close to the uterus, that's where your fertilization is going to happen. It doesn't happen in the uterus and it doesn't happen way up. It happens towards the end of that tube. And so you want to make sure that you are increasing your PEG cells, so you're increasing the nutritive environment for it. So that's pretty intuitive right there. It makes sense that the PEG cells would increase and ciliated decrease. And then you have a thick mucosal layer. Now the uterus, it's simple columnar with simple tubular glands. Stratum basale it's retained after menses status post. That's what that means. That's extremely important. You need to understand that stratum basale is retained after your menstrual cycle. So highlight that. Stem cells for structural stratum functionality, origin of glands. That wasn't, I don't remember that being as high yield, but you do need to know stratum basale. And then the stratum functionality, this is shed during menses, and then it thickens under the control of estrogen. This makes sense why this layer is the one that is shed, because this is thickening under the control of estrogen. And so once you have the stimulation to go through menses, this would be the thing that is going to be shed because it was one under the control. And then proliferative, early secretory, late secretory. I feel like I should have, why did I put SOT? Oh, that was just in my notes. Glandular secretions with oh, I don't think that was the point I was trying to make there. Sorry. Biggest thing, stratum and basale. So functionality, this is the one that is thickens, and then it is the one that is shed. Straight gland with narrow lumen that doesn't reach the surface. I think I feel like there should be words on this slide. I don't know why I just put pictures. Sawtooth is just a description, honestly. It's just a description that we use. So like fried egg appearance, you can actually use that for a lot of different things other than the examples here. It's just how we like to differentiate. Okay, myometrium hyperplasia during pregnancy under the influence of progesterone. They contract under the influence of oxytocin, and then it's slightly thicker after birth. Okay, the placenta, these are all the things it secretes. Then fetal chorion derived from, okay, what was most important here? Okay, you need to know the layers. Did you guys have, I forgot what his name is, but the professor at the beginning of the fetal membrane lecture, all he did was draw. It was like 30 minutes of him drawing the fetal membranes, and he did all of the layers, and it was very condensed. And then he's like, okay, that's your lecture. So now let's go through the slides. Did you guys have that?
No, we had Montalbano.
Okay. Because I might screenshot that and post it for you. It's just my drawing that he did, but it maps it out pretty simply, so you know the different layers, the fetal membranes. I'll do that for you. I'll just screenshot that and then post it later. But the big thing here, the decidua basalis, this is the, let me look at my notes real quick. The decidua basalis is the maternal component that forms the placenta. That's huge. So very high yield, highlight that, star that. That's a point that they like to focus on. But the layers, this is really just, I think that's what I'm going to screenshot you. So I'll show you guys that later. And the cervix, you need to know the different zones. That is very important. Okay, so the transformation zone, this is the abrupt change from the endocervix to the ectocervix. Squamous epithelial lining shed. You can get metaplasia here. Remember, they love the concept of metaplasia. And so if you have an injurious agent that is at an area, over time, the cells can adapt, and the adaptation is metaplasia, and metaplasia is reversible. But if you get it for a long period of time, you get dysplasia, and that's when you get malignancy. And so transitional zone, you can get this metaplasia. That's very important. So understand that concept. I don't know if they put a slide of this on here or if it was more just the metaplasia concept. But understand that, because they love, anytime they talk about a transitional zone anywhere in the body, you can get that metaplasia and they love it. The vagina, non-keratinized, stratified, squamous. This next point I spent a really long time on, but I don't remember it being a huge thing, but cells store glycogen that is released and it's converted to lactic acid, and that, oh no. It's converted to lactic acid by the local bacteria to decrease pH and protect against infection. I spent a really long time on that, understanding that concept and why it's important, but I don't remember that being a huge thing on the exam. But I do remember that the non-keratinized stratified squamous was something that they harped on in MCQs, I believed, in IMCQs, which is understanding the actual cell lining. Okay, the breast, you have the secretory portion. So you have inactive terminal ductules with simple cuboidal epithelium, and then you have a larger proportion of stroma versus glands. I'm not gonna lie to you, both Brady and myself, Brady can correct me if I'm wrong, we didn't think this was very high yield, and it was very high yield on the subsequent exams. Like, they had a lot of questions over this, but I don't even, I don't know if, like, to this day, I still quite understand the point that they were trying to make here. But I am telling you that in the past couple terms, they have liked this. So just hint, hint, wink, wink, spend a little bit of time on this. And you need to know the difference between an adolescent, an adult, and a lactating adult. And that's important there. I think I have another. Yeah, so active, you have the acinus, so proliferative, well-developed ducts and glands in late stages of pregnancy, and then lactating. Okay, so you need to know that this is inactive, and then active is on the left, and then lactating breast is on the right. You do need to know that, and they'll probably ask you, like, which of the following, they'll give you a patient, and then which of the following is most likely a biopsy from this patient, and it would be like a lactating female or something along those lines. So just understand that. Does anybody understand this really well, the difference between these two slides, that wants to unmute themselves and go over it with us real quick?
Yeah, let me chime in a little bit, Lindsey.
Go for it.
Yeah, it seems to me that you compare the stroma and the ducts. So when you have a lot of ducts, like the image to the right, we're having lactation. Then when the stroma is larger, look at the image to the left. When we have more of, so I think that's just the primary difference.
Yeah, I see what you're saying, and I did notice that difference too. There's a big difference between those. So,
sorry, can you repeat that?
Hey, let me just chime in real quick. So the question they did ask in our exam, and I agree with Lindsey, we didn't feel it was really high yield, but the previous term it was. If they're gonna ask you guys, I put mine, they would ask you on about the inactive breast, because all the different sequences here, this is the easiest to identify. Once you get to the point where you're going from proliferative versus lactating, like maybe that they're side to side, you can kind of see that, you know, this area where the milk production is, these little vacuoles are a little bit larger here than here, right? You can kind of see they're a little bit larger. But other than that, I mean, unless they're side to side, it's really hard to tell. So if I had a bet, they'd probably show you this inactive duct just because, or this inactive breast, just because, yeah, it's pretty obvious. There's not a lot going on here. But yeah, it's definitely worth looking at the histo pictures for that stuff. Yeah. Okay, yeah, go ahead, Lindsey.
Yeah, so someone said they couldn't hear you very well, so I'm going to just reiterate what you said. You said that if you look at these images side by side, you can tell that there is a difference between the amount of stroma here. But if you just put one of them on their own, you might not be able to see that. And so the comparison might be made more towards the inactive versus active breast. And so here you can clearly see that there is a large area of stroma versus the active breast, where you're getting less stroma because you are getting the proliferation of the ducts and glands. And so by simple proliferation, you're taking over more area than the stroma. And so here you can see, comparing side by side again, you can see that there is a difference. But do understand that there is that difference. And somebody commented that in themed office hours, they did hit the point of the difference in the amount of stroma here.
Sorry, just to confirm. So, sorry, you go. Just from inactive to active, then to lactating, it just gets like less and less stroma and more ducts, right?
Absolutely, yeah.
Okay, thank you.
Yeah, you see a lot of dense connective tissue here versus all of these active, these terminal duct lobules too. You can see this clumping. Yeah, that's about it. But yeah, I don't think any of us went into this exam feeling very comfortable with all this breast.
Yeah, no.
So if anything, I'd bet on this bad boy here because it's not most obvious to detect or identify. All right. 4 hours, not too bad. As always, I'm on Scrubs, Lindsey's on Dog Mile, and that is all we have. Do y'all have any questions for us?
With the histo, I feel like when you get to more of these systems, even though the amount of histo questions increases, the difficulty to some degree decreases, simply because you can put them side by side and compare them along the path. That's why at the beginning of the histo, I said the pathway of the spermatozoa. And so put them side by side, say, okay, this is point A and this is point B, point C, point D, and look at it and just be able to tell the difference between them, and then relate that back to the function, relate that back to what it's secreting, why that's important. So there are a couple places where it gets a little more intense, with the convoluted versus straight ducts and rete testes, and then actually in the seminiferous tubercle, when you are looking at the different areas, that's probably the most complicated for the male histo. And then of course, female histo, it's all of the follicle and oocyte stuff. But that's going to be the hardest, and that's what you should probably focus on if you are stressed out about it. But other than that, just put them all side by side, understand that it's point, start point, end point, and then just be able to recognize it.
All right.
I just had a question. I just had a question. So I see on your drive that there's week 3, the week 3 for repro, but I can't find the associated video. Is there one?
Right. So what happens in the last term happened is the same thing for you guys. So that week 3 material, they had their exam on Friday too. So what I did for them is I just put those slides together. We're not going to be able to have a review. I mean, we're going to be studying all week. So just try to go through those review slides. I made it pretty self-explanatory what I felt was important because we don't have a video review. But I just wanted y'all to have something for that material.
Awesome. I really appreciate it.
Yeah, no worries.
Thank you so much. Have an excellent day. Thanks for your time, eh?
Yeah, good luck, guys. Try to get your points where you can. If we don't end up finishing the repro off for you, just know that they really love the hormone graphs for the female. They really love those graphs, and they like to relate them. They like to relate the hormones to each stage of the menstrual cycles. So, you know, follicular phase, luteal phase, match that up with all of the hormones. They love to do that.
All right, that's it. I'll stop the recording. Again, good luck. If y'all need anything, just message us. No worries.